Yeah, so once again, welcome back to the platform of Medical MCQ for All. And probably let me check my this PowerPoint. Sorry, but yes, that's correct. So sorry for date wrong here. It's a 25th today. So welcome everyone. Today we have excellent speaker as usual, Dr. Akanksha Gosavi, and those who are joining us first time. This is one of the best class today, I will assure you. So you get the feel at the end of the class. So we are the coaching company mainly with providing online subscriptions, hard copy book and various packages, data flow services, dental program, and now included the homeopathy as well. Another exciting news is me and my team, including Dr. Akanksha, Ramya, Dr. Kainath, and other Pooja and Meghna. A lot of people are there in the team. So most of the team now, this time, first time would be in a major. The number will be available in Dubai from 7 to 14 February. So next of the next Sunday we will be there. So would be happy to see you all guys. Just let me know who is joining us. Right, my number is there. This is my number, so you can drop me message if you guys are interested. Meeting and greeting, small get together, so we can manage and we can meet properly everyone. Next thing is for joining first time, I am Dr. Munjal, hemato-oncologist and bone marrow transplant fellow, practicing 20 plus years and having a nice academic interest and experience in teaching, coaching, mentoring. And I'm member of American Society of Clinical Oncology and Hematology. So we'll take you to the nice journey of hemato-onco in some dedicated stuff. And Dr. Aarti is our consultant pediatrician, wonderful speaker as well. Dr. Madi is also our the internal medicine doctor based at Oman. And as you know, very popular in our communities, Dr. Akanksha Gosavi, wonderful teaching experience and clinical experience. She has a wonderful experience teaching internal medicine people, MBBS, NEET, PG, FMGE, next aspirant, and she is a faculty at many international platforms, including Russia, Kazakhstan, and Kyrgyzstan, and lot more on her name. So we would be happy to have her today in her class. Along with that, we have another, I mean, nice team of Dr. Sonal Shah, who is a emergency physician. Dr. Meghna is head data flow based at Dubai, and this team, Dr. Ramya is gynecologist. So probably we are planning to take and do one mock test with Dr. Ramya soon. Dr. Pooja is like a dentist, and Dr. Kainath is consultant homeopath. So this is our team, and last but not the least, Pallavi. Everyone knows Pallavi. She is like coordinating with each and everybody. This is our details. This is excellent ProMetric 1000 MCQ book with answers and explanation. And we have many discounted offers and mega offers and all. So you can inquire later on, which gives you around 50 to 70% discount as well. And last but not the least, before handing to Dr. Akanksha, this is our amazing YouTube channel, very popular in short time. We have hundreds of videos. I strongly recommend and request see at least one video a day, not more, at least one video a day. Let me tell you, your mindset would be absolutely changed, and you are absolutely convinced with the all conceptualized learning. It's not just the mug up. So see at least one video a day, right? Which will, like by my sense, equivalent to doing 50 to 100 MCQ a day. So just spend 1.5 hour. That would be great for you. And last but not the least, try to do a practice of mock test. So mock test is extremely important because without mock test, it is like, I mean, incomplete preparation. In mock test you get to know how to prepare, what to prepare, what kind of questions will come in exam, and try to check your score and do the self assessment where exactly you are standing before going for the exam. So this is kind of like you can, you by yourself, you know how you supposed to do in your exam and you pass or not before giving the real exam. So mock tests are there all subject wise, so do. And last but not the least, we have like coaching company for EMREE as well. I'm a co-founder of EMREE Prep. Those who are preparing for residency exam in UAE, this is the exam. Dental and homeopathy we already started. So just need your support and a little spread the uh, a word of mouth to your friends, those who are interested in dental and homeopathy. They can join, and these are the discounted various packages. So that's all from my side. Now, I would like to hand over to Dr. Akanksha Gosavi, who is a consultant internal medicine physician. So I'll request ma'am to just take over your first session, and then I'll take over after 1 hour.
Thank you, Dr. Munjal sir, for the lovely introduction and about all the details of our platform. Good afternoon, everybody. So let us
One
move
minute.
on
I'll make
for
you the host. I'll make you the host,
yes,
ma'am.
yes, sir.
Now you are the host, so you can take over, and then once you finish, just make me a host. Thank you.
Yes, thank you.
Yes, please.
Okay. So I hope everyone can see my screen. Today we are going to revise internal medicine as we had taken the poll that what subjects we want, and it was highest for the internal medicine. In internal medicine, that too we'll be doing neurology. That is the main part for today. So let us start with no further delay. Okay. So this is the first question for today. A 72-year-old man presents with resting tremor, rigidity, bradykinesia, and postural instability. Symptoms are significantly affecting the daily activities. What is the most appropriate initial therapy? Salicylin, amantadine, levodopa plus carbidopa, or bromocriptine? Please give your inputs for this question. I'll just give you 5 seconds, 10 seconds. And also tell me what is your diagnosis.
Parkinson's disease.
Okay.
Answer is C.
Okay. I just got two answers. Where is everyone?
Parkinson's disease.
Okay.
It's levodopa and carbidopa.
Okay, fine. Perfect. So the correct answer for this is the Parkinson's disease, which is the diagnosis for this problem. And the correct answer for this question is levodopa plus carbidopa. Can anyone tell me what exactly is Parkinson's disease? What do you mean by Parkinson? Or what are the main triad of Parkinson symptoms? Okay. No active voluntary interactions today.
Lead pipe rigidity,
Okay, fine.
ma'am, it's a disease. A triad is resting tremor, lead pipe rigidity, and
Okay,
akinesia. And
okay,
this the difficult, the disturb to maintain the posture, difficulty to maintain the posture.
okay, very good. So thank you for the inputs, Dr. Rabia. Basically, in this question, we have to concentrate on the main words. Now, what are the main words here? Here is the resting tremor, rigidity, bradykinesia, and postural instability. So, all these four parameters is going to lead us to one part that is going to be Parkinson. Okay. And when we think of Parkinson, the correct combination being this person or elderly has to be your levodopa plus carbidopa. Okay. Now, let us come on for the exact explanation for this. See, what is Parkinson's disease? It is a chronic progressive neurodegenerative disorder of the XPS, that is extrapyramidal motor system. Okay, so when we talk about extrapyramidal motor system, that means your all extrapyramidal pathways. Now, what happens is the substantia nigra, it has dopaminergic neurons. Now, this dopaminergic neurons in the substantia nigra, they degenerate. So, for example, in a normal substantia nigra, this is a part of substantia nigra, this is going to be the number of neurons in a normal scenario. But what is going to happen in Parkinsonism? There is going to be only one layer of dopaminergic neuron. So there is going to be exactly deficiency of these dopaminergic neurons from the substantia nigra. Okay. So what happens is, due to this dopaminergic neurons, the number of neurons are reduced. What is going to happen? The number of dopaneurons, they are going to be reduced. Now, if the dopaneurons are reduced, what is happening? The normal physiological action of dopamine, that is in generally reduced. Due to this, there are going to be primary symptoms, that is the disorder of the movement and the disorder of the motor strength. Therefore, there has to be dyskinesia or bradykinesia, that you can call it as. Then you can have the automatic movements. There is no voluntary movements. There is tremors. So all these symptoms will be happening due to the number of degeneration of the dopaminergic neurons in the substantia nigra. Remember this very well. Okay. Now, whenever you diagnose this, Parkinson as such is diagnosed very clinically. Okay, so whenever a patient is coming to you, only the sign symptoms are sufficient to diagnose the Parkinsonism. Bradykinesia is mandatory. So what is going to be mandatory? The slowness of the movements. That is, any movement that you ask the patient, there is going to be slow movements. Also, you ask the patient to write. You give the patient the pen and paper to write, and once there is going to be pen paper, you ask the patient to write his name. You will find there is going to be micrographia. I guess I have written it here. Yes, there is micrographia. Okay, so micrographia is a very common and it is the earliest sign. Micrographia means what? For example, I am writing here Parkinsonism. So I am writing it well. But if a Parkinson patient is trying to write, he is going to write something like this. So this is micrographia. It is going to be slow as well as it is going to be small letters. Okay, so this is going to be the first and the earliest sign. After that, you can have bradykinesia, you can have fatigue, you can have resting tremor, rigidity. As Dr. Rabia said, it is lead pipe rigidity, postural instability. So all these symptoms, they appear slowly, one after the another. Ideal presentation of all the symptoms in one patient is not very common. You can have bradykinesia, you can have micrographia, you can have tremors. But in another patient, again, bradykinesia is there, tremors is there, but micrographia is not usually seen. So there can be varied symptoms, but clinical diagnosis is one of the major signs for getting you Parkinsonism, or coming on for the conclusion that the patient has Parkinsonism, and then you can start with the treatment. Now let us see what are the actions of dopamine in the body. As you know that the dopaminergic neurons, the number of dopaminergic neurons, so that is going to be reduced, right? So this number of neurons, when they are getting reduced, what is going to happen? The reward and motivation feeling, that is not going to be there in the body. That is not going to be there in the patient. Therefore, the patient is going to face depression. So depression is also one of the symptom of Parkinson patients. Then cognition and executive function. So whatever is the normal role of your dopamine, exact opposite is going to be the patient of Parkinsonism. Therefore, we have seen this diagram. There is cognition and executive function. Therefore, like the patient can make decisions, he can think well, he can memorize. So all this is also going to be reduced. Prolactin inhibition in a normal person, but in Parkinson patient, your prolactin levels are going to be high. Okay, so prolactin is going to be raised. Then behavioral thing or a stress response, the patient can get into arousals or impulses. He can become very, again you can say, slow, or the impulses that are there, they are going to be reduced. Okay, coming to the cardiovascular part, cardiovascular, what is happening? The heart rate, it is going to be very low. Why? Because normal dopamine increases the heart rate, it increases the renal blood flow, and it causes vasoconstriction. But now heart rate is going to be low and there is going to be vasodilation in a Parkinson patient. Coming to the GI motility is going to be reduced. So the patient is going to complain of constipation. Okay. Renal functions, again there is going to be sodium excretion which is going to be reduced. So therefore, if sodium excretion is going to be reduced, the patient can have hypernatremia. And movement control, because dopamine facilitates voluntary movement. This is the reason for having bradykinesia, that is voluntary movements are reduced very often, and the motor activity is also going to be reduced. So therefore, due to the abnormal action of dopamine or reduced dopamine in the body, especially in the substantia nigra, Parkinsonism takes place. Now, whenever we start a therapy for Parkinsonism, the treatment of choice is always based on the age and on the functional impairment. So, if it is for the younger patients, what do we decide in younger patients? We decide that dopamine agonist may be used initially, and therefore, in younger patients, what is the drug of choice? Can anyone tell me what is drug of choice for younger patients? Yes?
Bromocriptine.
Okay. And why bromocriptine, dear?
Dopamine agonist.
Yes, right. So we can give bromocriptine in a younger patient. But if it is an elderly patient, just like it was in our problem right now, what do we have to do? We have to give a combination of levodopa plus carbidopa. Okay, so dopamine agonists cause hallucinations and hypotensions. So that is the reason that they are not indicated in elderly patients. So when we are talking about only dopamine, or only dopamine agonist singly, it has to give you more hallucinations and hypotension. So therefore, they are not given as a single therapy into old age patients. Coming to the golden rule, elderly patients with disabling Parkinson disease should always be started with levodopa and carbidopa. Okay. Now, see this. These are the sign symptoms of Parkinsonism. That is Parkinsonian gait. The patient is bending. There is going to be mask-like faces. Asymmetric resting tremor. Asymmetric resting tremor. Why? Because voluntary movements are losing the control. Voluntary movements, they lose the control. That's the reason there is going to be asymmetric resting tremors. Postural instability, shuffling steps, or shuffling gait, what you call it as. Then you have the muscle rigidity, you have the freezing of the muscles, again due to the voluntary movement, or the tone of the muscles as we saw is reduced. Then you have the reduced arm swing, the slow movements. So all this comes up like a Parkinson patient. Now, what are the drugs of choice in typical cases? So, whenever we see the Parkinson patient, what is the first line that we talk about? We always talk about levodopa plus carbidopa. We give it togetherly. The reason being why? Because one increases the absorption of another. So, therefore, levodopa and carbidopa is always given togetherly. It is always 100 mg plus 125, plus 25 mg, and that is going to be given 3 times a day. And this is the drug of choice for elderly patient. Okay. Coming on for dopamine agonist, that is your pramipexole, ropinirole, or your rotigotine. Then you have, it is given usually for the younger patient, 0.5 milligram 3 times daily. This is shown very significant improvement, especially your pramipexole and ropinirole. These two drugs, we are using it very widely, and it excellent gives the results in case of younger patients, because younger patients are ought to go for job, they are supposed to do the working, and they cannot be home debilitated. Therefore, we have to give pramipexole or ropinirole at a high dose considerably in the younger patients. Now, coming for MAO inhibitors, that is monooxidase amine inhibitors. These are going to be your selegiline and rasagiline. So, what type of reaction does MAO inhibitors cause? Can anyone tell me?
With antidepressants, they can cause serotonin storm.
Okay, what else? Selegiline and rasagiline, that is MAO inhibitors. What reaction they can cause? Something very popular.
Cheese-like reaction.
Yes, perfect. So, is like reaction. It is a hypertensive crisis. Cheese like reactions, that is selegiline, rasagiline. So MAO inhibitors causes cheese reaction due to the inhibition of what enzyme?
Monoamine oxidase enzyme.
Yes, monoamine oxidase, that is perfect. But due to there is something with T. What is that?
Tyramine.
Yes, due to the tyramine. That is tyramine rich foods. Just like a patient is eating cheese, or he's eating red wine or drinking red wine, he's eating the barbecued meats, soy sauce, fermented foods, all these are tyramine rich foods. So someone who has this cheese reaction has to always eat lesser tyramine rich foods, and this is the main reason that the cheese reaction occurs due to inhibition of MAO, that is monoamine oxidases, plus the tyramine. They togetherly cause cheese-like reaction. What is the main thing for this main symptom of cheese reaction? That is the hypertension crisis. Okay. So MAO inhibitors, they are going to cause what? They are going to cause you the cheese reaction, and it is going to cause you hypertension crisis. Remember this, simple as that. And what are the drugs that can cause cheese reaction? That is salicylic, rasagiline. Okay. And the foods, if you ask me, that can cause cheese reaction, they are going to be what? They are going to be the red wine, it is going to be meat or beer and nuts. These are what? These are the tyramine rich foods. Okay. Tyramine rich food. Now, coming to the COMT inhibitors, we have another newer class of drugs, that is entacapone or opicapone, which can be given adjuvant to levodopa. Sometimes the levodopa and carbidopa, they show a on and off phenomena. So therefore, whenever we see an on and off phenomena, after many years of usage of levodopa, carbidopa, we can add up entacapone to it, and it can be given adjunct to levodopa to manage motor fluctuations. Coming on again for NMDA receptor agonist, entacapone, opicapone, same thing can be given for your motor fluctuations. And drugs used for Parkinsonism, the last one is amantadine. We can give it 100 milligram twice a day. But what is the reason? It is used for levodopa induced dyskinesia. Whenever there is going to be fluctuation of the movements, you see, always remember, whenever we give levodopa, after years of usage of levodopa, it is going to show some resistance. It is also going to show the on and off phenomena in Parkinson patient. During this time, we are supposed to introduce another class of drugs into the patient. Either it can be your entacapone, opicapone, which is your COMT inhibitors, or you can use your amantadine. Okay, so this is as simple as that. Now, as we were talking about the substantia nigra part, what I was telling you, in this image, you can beautifully see this is the substantia nigra, that is the black color area. Here, the number of dopamine neurons, they are reduced. And whenever, see, this is the normal one. You can see this. Normal patient has very good substantia nigra. There is no depletion. But here in this Parkinson patient, there is depletion of this substantia nigra, which is at the base of the brain. See here, it is so healthy. But in Parkinson's disease, what is happening? It is all depleted. And that is the reason that the dopamine is reduced, and therefore we have Parkinson. Now, this is Levy bodies that you see in substantia nigra neurons. This is one liner for your exam. You have to remember that. What bodies do you see in Parkinsonism? That is going to be your Levy bodies. Okay? Okay. So, any doubts in Parkinsonism anyone has? Yes,
No,
students,
ma'am.
any doubts? Okay,
No,
yes,
ma'am.
one thing I missed. How do we diagnose Parkinsonism we were talking about? Diagnosis first was your clinical. Okay.
Clinical.
Yes. Then you have something that you call it as DAT SPECT scan. What do you see in that spec scan? You see dopamine absorption or dopamine uptake in your DAT spec scan. So if they ask you one liner, that is imaging diagnostic for your Parkinson, then it is DAT spec scan. Also, sometimes we can do MRI, but MRI is not that sensitive. So it's not going to show you much of the difference. So therefore, MRI is not recommended, although you can do it, but that spec scan is the most specific diagnostic test for your Parkinsonism. Okay. Anyone else has any doubts about Parkinson? And the full form of your DAT spec scan is going to be dopamine transporter spectra scan. So this is going to be a dopamine. concentration, you're going to see that that is the DAT scan. It is going to be showing you reduced values because the dopamine is going to be reduced. All right. Okay. So now moving ahead with the next question. A 45-year-old man presents with progressive ascending weakness for 4 days following a diarrheal illness. Now the examination shows areflexia and bilateral facial weakness. Vital capacity is declining. What is the most appropriate treatment? IV methylpred, oral prednisolone, IV immunoglobulin or azathioprine?
C. IV immunoglobulin, ma'am.
Okay. Yes, everyone, please post your answers.
Guillain-Barré syndrome IV immunoglobulin.
Okay, very good. Yes. I'm just giving you more 2-3 seconds. Okay. Yes, as all the smart students have said, it is IV immunoglobulin is the right answer for this, and the diagnosis for this is going to be your GBS. Okay, that is your Guillain-Barré syndrome. It is one of the very high yield topics for your exam. That see, always remember that in the mock test we are keeping such topics only which are the highest yield for your DHA. That is, it is compulsorily going to come in your exam. So pay attention for all the topics that we are covering. All right. So Guillain-Barré syndrome, immunoglobulin IV is the thing that we are going to do. And there's another treatment part. Along with IVIG, we can also do plasma
exchange.
phoresis. Yes?
Plasma exchange.
Yes, right. Plasma exchange, plasma phoresis. So these two are the main pillars of your Guillain-Barré treatment. Now let us see in detail what exactly it is. Okay. So IVIG here it is important. Why? Because it is going to be rapidly modulating your immune response, neutralizes the pathognomic antibodies, reduces the severity of the weakness, and shortens the time to recovery. So that all pointers they are going to promote your IVIG. Okay, so IVIG, what is the dose? It is going to be 0.4 gram per kg per day for 5 consecutive days. You have to give it in only one dose. You cannot divide the IVIG dose into 3 doses, 5 doses. No, give it only at once. Give it very slowly and at the dose of 0.4 gram per kg per day. Okay. Now, in the patients with progressive weakness, cranial nerve involvement, and declining vital capacity, which is already there in our patient, in this people, we have to give IVIG. The steroids, it is not a correct mode of treatment for your Guillain-Barré syndrome. Guillain-Barré syndrome, if it is, then only two answers should be there. One is IVIG and as I told you, one is plasma phoresis. This is the only treatment for your Guillain-Barré. See here, why we are not giving corticosteroids? Because they do not improve the outcome, especially whenever the functional vital capacity, that is FVC, it is reduced. That time, immediately IVIG and plasmapheresis should be done. Azathioprine, it is again a immunosuppressant and it has no role in your Guillain-Barré disease. Okay, so when I ask you what is a Guillain-Barré disease, let me tell to you in short about Guillain-Barré. So Guillain-Barré is what? It is always a acute condition in which there is going to be immune-mediated polyradiculoneuropathy. So when I say this word, that is immune-mediated, everyone must be knowing that immune-mediated polyradiculoneuropathy. What is the meaning of polyradiculoneuropathy, anyone? What do you mean by this word? Polyradiculoneuropathy. Yes. See, basically, it means that it acts upon the immune bodies. They are going to act upon the various neurons in the body in a typical group of areas. Supposedly, it is respiratory, it is the limbs, or maybe it is the abdominals. So, it is going to act basically into a group of all the neurons in that area. Okay, so that is going to be your immune mediated polyradiculoneuropathy. It is now in Guillain-Barré patient. What do we see? We see rapidly progression, limb weakness. So one more thing you have to remember in your Guillain-Barré. First is going to be limb weakness. So for example, this is the patient of Guillain-Barré. The weakness is always going to start from the limbs and then comes to the central. So first limb weakness, then goes to the central part. So initially the weakness is going to be in the upper limb or in the lower limb. Then the patient's respiratory muscles are going to be compromised. First, the respiratory or the thoracic region, never compromised. Then it cannot be Guillain-Barré. Remember this. If the respiratory muscles are showing non-functioning or dysfunctioning, then it is not Guillain-Barré. Only when limbs first gets weakness or paralysis, then comes to the central part, then 110% it is Guillain-Barré. Okay. Now, why Guillain-Barré is dangerous or why Guillain-Barré is life-threatening? Because it is going to cause you respiratory failure, or the respiratory muscles, they become weak. Respiratory muscles, they become weak, and therefore there is loss of respiration, and therefore this is the emergency. As such, Guillain-Barré is not an emergency, but when it affects your respiratory muscles, that time there is going to be respiratory failure. Why? Because the respiratory muscles are not able to function well. The accessory as well as the main muscles of respiration, these all, they are not functioning well. It is having weakness and it is going to cause you respiratory failure. Now, why does this Guillain-Barré occur? What exactly is the pathophysiology in Guillain-Barré? Now, when we say that Guillain-Barré, it is an immune mediated, that means antibodies are formed across the nerves. So when I say, where is it? So it is a antibodies, they will be formed and they are going to lodge itself on myelin sheath, on the myelin sheath of neurons. Okay. So whenever there is going to be antibodies, they are going to be formed on the myelin sheath of the neurons and therefore cause the neuronal or the axonal damage. And I have an image, 1 minute here. Okay, so see this. So this is a healthy myelin sheath. This is the node of Ranvier. There is good saltatory conduction. And this myelin sheath, you see, there are wonderful layers out here. So it is a healthy one. But when the antibodies are formed, what is happening? This is going to damage the myelin sheath. Damaged myelin sheath, and this is going to cause the exposed nerve fibers. And due to this, there is going to be weakness in the muscles. Why? Because the heavy neurons, that is your myelinated neurons, are the larger ones in the body, and these neurons, the myelin sheath, it is not acting well. There is no fast conduction, so therefore impulses will be reduced, the motor activity will be reduced, there will be muscle weakness, and that is the reason that the Guillain-Barré syndrome will take place. Okay. Now, coming to the main causes of your Guillain-Barré, it is basically your virus or a viral mediated thing, you can say. And the most common virus for your Guillain-Barré has to be your CMV or your Epstein-Barr virus. Then can sometimes be your COVID-19. Post-COVID, we have had so many patients with Guillain-Barré COVID-19. Okay. But main two, if it is a choice, the first option yours has to be your cytomegalovirus, which is the most common one. Then comes your Epstein-Barr virus. Okay. And also, if it is again a single answer, then your answer should be your Campylobacter jejuni. Campylobacter jejuni, again, which is transmitted by what? It is transmitted by water or food. Water and food mediated. Most common trigger is your Campylobacter jejuni, and this is the reason that it is going to cause you diarrhea in a Guillain-Barré patient. Now, CSF findings on Guillain-Barré, you will have albuminocytologic dissociation. First line treatment, IVIG, plasmapheresis. Steroids has no typical role, and the most serious complication for GBS is going to be respiratory failure. And the most common cause of AFP in adults is going to be Guillain-Barré. And the most common cause of AFP in kids, what is that? Can anyone tell me? Most common cause for AFP in kids?
Poliomyelitis.
Yes, very good. So it is
Acute
polio.
poliomyelitis.
Yes, right. Perfect. So it is going to be polio. All right. Now, whenever we are talking about GBS, there are also other two differentials that you should be knowing along with GBS. One is your GBS, second is your myasthenic crisis, and then is your botulism. Now, when we talk about GBS, it is going to cause you peripheral nerve demyelination. That is the reason that I told you it is going to be affecting your limbs. But in myasthenia gravis, what is happening? It is occurring at your NM junction, that is your neuromuscular junction, and your synaptic clefts and all that mechanism everyone knows. This is going to be affected, and this generally causes in the central region. Maybe in the eyes, then it in the central region, but never in your peripheral. Botulinism, what is happening? It is a presynaptic defect, and therefore the acetylcholine release is blocked. But here we have the level of lesions at peripheral nerves and nerve roots. It is a postsynaptic defect, your myasthenia crisis or myasthenia gravis, and presynaptic is going to be your botulin toxin or botulinism. Now, what is the weakness pattern? Weakness pattern is going to be ascending and symmetrical. Ascending means what? From the limbs towards the central. That is from top to bottom. Then here it is going to be fluctuating and it is vegetable. That is more fatigue. Fatigue is going to trigger your myasthenia crisis or your myasthenia gravis. And botulin, it is again descending type. Reflexes, they are going to be decreased or absent in Guillain-Barré, but reflexes are normal in myasthenia crisis. And again in botulin, many of the time we have seen patients, the reflexes are very normal, but sometimes they can be late. The common cranial nerves to be involved is the facial palsy one. The common is here oculomotor, which is going to cause you ptosis and diplopia, and here not so much involved. Pupils, again normal reaction everywhere, but in botulinism, the pupils are dilated or they are fixed because it mainly affects your face plus other region. The botulin toxin generally affects your face. Now, what is the history? That is going to be more common in your GBS. You will have the patient that is going to have diarrhea or viral illness, or maybe he was traveling, he had drunk some water from some river or some well. Some like this rural area question they can put that he had gone traveling for some rural area picnic, he had this contaminated water, or he drank water from the external resources which was causing him diarrhea, vomiting, then he had fever, and after that he had suddenly respiratory weakness. Now, sorry, excuse me. Now, when you talk about myasthenia gravis, there is going to be already a patient who has a history of myasthenia gravis. There are supposed to be few drugs which caused him this crisis or few infections which caused him the myasthenia gravis. Now, canned food or some wound. What wound exactly? So, there is going to be Clostridium botulini. This is going to cause you any wound from any metal objects or a rusted metal object, and certain type of canned foods can cause you botulinism. Now, what is the first line treatment we have seen for GBS? It is IVIG plasmapheresis. Again, the same thing for your myasthenia crisis also. And in botulin, you do not give any of this, but you give botulin antitoxins. Antibiotics has any no role here, and only botulin wounds you can give antibiotics. And what would be the choice of antibiotics? It has to be metronidazole because it has a anaerobic coverage. So metronidazole would be the choice of antibiotics in your botulinism. Okay. So I hope this is clear for everyone what exactly is GBS and what is happening in GBS, that the myelin is getting disrupted. See here. As I told you, this is about the myelin. There is going to be limb weakness. There is going to be difficulty in swallowing, shortness of breath, and flaccid paralysis. Now, we have the GBS subtypes. Subtypes are what? It is going to be polyneuropathy demyelinating type. That means the antibodies, they are going to injure your myelin sheath. This myelin sheath is going to be injured and there is going to be antibodies are going to damage. So therefore here conduction is going to become slow. Conduction is going to become slow. Why? Because myelin sheath is responsible. We call it as saltatory conduction. The myelin, the more myelin sheath the neurons have, the more faster the conduction is going to be. Now here what is happening? It is going to affect your axon, sensory axonal path. Now this is a non-myelinated, but it is damaging your this part. This is damaging your axons down. Okay. So now this axons are damaged. That means there is no further transmission of signals. no further transmission because axons, they are disconnected, they are damaged. Okay, and this is your basic normal motor neuron. Was GBS clear for all of you? Any doubts in GBS?
Yes, ma'am.
Basically, it was caused by what? Tell me the five causative virus, or tell me three. Three causative virus.
cytomegalovirus, and
Ma'am, it's
CMV.
Epstein-Barr virus
Hmm.
and post-polio, post-COVID-19.
Okay, very good. So CMV, then Campylobacter jejuni, Epstein-Barr, and COVID-19. These are the main causative organisms for your GBS. Then,
Uh,
does GBS have diarrhea and fever?
excuse
yes,
me, ma'am.
Yes.
If yes, ma'am. Excuse me, ma'am. When question come in exam, what is our best choice? If question is coming,
See, if
which
there are
virus
four
causes
options.
the GBS?
Yes. Okay, so most common
If
cause
we
for
have all
GBS.
four,
Campylobacter
yes.
jejuni should be your answer.
Campylobacter jejuni is our best choice among all four.
Yes. And after that, CMV. After that, EBV.
Okay, ma'am.
Okay. In some questions, they cannot give you Campylobacter. Some questions, they cannot give you CMV. They'll only give you Epstein-Barr. Okay. So when these questions come, what should be your answer? Epstein-Barr, because it is the third favorite. So first choice should be Campylobacter jejuni, and after that is your CMV.
Okay, ma'am.
Yes. And what is the treatment for it? GBS, what is the treatment?
IV immunoglobulins.
And
immunotherapy and
plasmapheresis.
plasmapheresis.
Very good. And what is the choice of antibiotic for botulin?
Metronidazole.
Metronidazole.
Very good. Because it has a anaerobic coverage.
Coverage.
Okay, perfect. And what is the complication, life-threatening for GBS?
Respiratory failure.
Respiratory failure. Respiratory depression.
Okay, perfect. So I guess you have understood this very well. Yes. Now let us move on for the next question.
Excuse
Yes.
me, madam.
Yes.
Yeah. In the question, if the patient developing respiratory failure,
Huh?
so if yes, what should be the first line management? We have to do the intubation, no? If there is, even though they mentioned the IV immunoglobulin.
Yes, first it is a common rule of the ICU. Firstly, the patient he is going to be inside the ICU for GBS. In ICU, we have to first do the ABC, that is airway breathing circulation should be stabilized. And after that, you go on for the treatment of the causating agent or what is the root cause. You treat that. Okay. So you cannot just leave aside that breathless patient and give him IVIG. No, you intubate him, stabilize his breathing because that is the first concern and then give him IVIG.
Okay. Thank you.
Clear?
Yeah. Okay.
Okay. So, someone read out this question for me. Doctor, who's there? Rabia is there? Read out this question.
28 years old woman present with recurrent prenatal throbbing of headache associated with nausea, photophobia, phonophobia. Their headaches last for 8 to 24 hours and worsen by physical activity. Neurological examination is normal. What is most appropriate, accurate treatment for it?
Yes.
Two diagnosis of primary.
The option A is propranolol, option B is
Sumatriptan.
somatropin, option C is and toptonet, and option D is amiodarone.
Main complaints हो जाए oral tongue में
Okay,
burning
fine.
है.
So basically, whenever you have the question on headaches, now first it is important for everyone to understand what are the main pointers. It is unilateral throbbing headache associated with what? Associated with nausea, photophobia. 1 minute. One minute. Sir's mic is on. Let me just mute this. Okay. So it has to be a 28-year-old young woman, okay, with recurrent unilateral throbbing headache. So one-sided headache associated with nausea, photophobia, phonophobia, and the headache lasts for 8 to 24 hours, worsened by the physical activity. Neurologically, she is fine. What will be the line of treatment? Now, what is the answer that everyone is giving us?
Yes.
Unilateral headache, ma'am. It's migraine.
Everyone is
Sumatriptan.
saying migraine, and what should be the answer?
Sumatriptan.
Sumatriptan for acute attack.
Okay, fine. So,
Migraine headache, and
agreed,
we give
agreed.
sumatriptan.
Okay, agreed. Fine. This is a right answer. Sumatriptan should be given. Now, let us see why sumatriptan. Okay, so this is a classical presentation of migraine without aura. Migraine without aura, that is unilateral throbbing headache, nausea, photophobia, phonophobia. Phonophobia means what? Scared of the phones?
No,
No,
scared of
voice tolerate
the
noise.
Yes,
noise.
right. So
Noise.
anyone talking that perfect. So anyone talking, yes. So
Noise
whenever, just like if I
agitation.
try to talk to that migraine patient, he'll be like, stop talking. I don't want to hear anyone talking. The patient will be very irritable. So anyone talking or any voice that is coming, that is going to be a phonophobia. Photophobia, that is the sensitivity to the light, which is worsened by activity. If you ask him to get up, get down, step down from the stairs, no, not at all. No activity will be done by the migraine patient, and he is going to have the normal neurological examination. So this is an ideal case of migraine headache. And in case of migraine headaches, triptans are the first line treatment for acute to moderate to severe migraine. Okay, so sumatriptan is what? What category of the drug is it? You should remember it is 5-HT1 or 5-HT1D agonist. So triptans is something which is very important, and they are going to cause you cranial vasoconstriction, inhibit the trigeminal nerve mediator neuropeptide release. Now, whenever we talk about headache, can anyone tell me what is the definition of headache? So basically, headache is what? It is the pain which is arising from the head and the neck. Okay, so any pain which is arising from the head and neck, and the main reasons, this is going to have your involvement of the dura mater, it is going to have your venous sinuses, then it is going to have your scalp. This, remember, this list is important, and it is going to have your neck muscles. So anything that is causing pain from all the structures, it is going to call you as headache. Okay, but always remember, the brain parenchyma or the lining outside the brain, it is always insensitive to pain. It's never that, someone is coming to you headache and the patient is complaining, my brain is paining. No, your brain can never pain, because the brain parenchyma doesn't have pain receptors. It is totally insensitive to the pain. But the structures which are outside the brain or maybe inside the brain is going to cause you pain, and that is going to arise either from dura mater, venous sinuses, your scalp, or your neck muscles. Okay, now as we see here, triptans are the first line acute treatment for your acute to moderate to severe migraine. NSAIDs are the first line for only mild migraine. That is only one episode in once 3 months. If the patient is getting, we can say that it is a mild migraine without photophobia, without phonophobia. Then propranolol is the prophylactic treatment of migraine. Remember this. For acute attack or during the attack, you give triptans. But during what you say, during the prophylaxis, that is in the maintenance, for that you give propranolol. What class of drug is propranolol?
Beta blocker.
Okay, very good.
Beta
These are
blocker.
the, yes, beta blockers. Yes, okay, perfect.
Ma'am,
Then,
how it's used for a headache beta blocker.
yes. Can anyone tell me why is it used for headache?
Increases the heart
Because
rate.
Ma'am,
they relax the
ma'am,
veins.
any mechanism behind it?
Yes, yes, it has mechanism. That is the reason I'm discussing. I'm asking people. Why?
Vasodilatory effect.
Yes, someone told me which effect?
Vasodilatory.
Vasodilatory. Okay. If it is vasodilation and triptans is causing vasoconstriction, my dear, will it be used?
No, ma'am.
Okay. So good
No.
question. Now let us see why does this propanolol or how does this propanolol act? Now I don't have space to write. I'll write it here. Okay. So if you're talking about propanolol, propanolol basically it is going to cause what? It is the drug which is going to cross your blood brain barrier. That is, it can enter into the brain. Okay. In this, it helps in reduces the vasodilation. It is not going to cause vasodilation, but it is going to reduce the vasodilation in the brain. First. Second, it is going to act on your 5-HT receptors and reduce the, what you say, pain. So, serotonin, what is going to do the action on serotonin? It is going to
Inhibit.
Yes, it is going to inhibit the serotonin and it is going to inhibit your HT pathway, that is your 5-HT pathway. Therefore, it is going to reduce the inflammation inside the brain. Okay. And therefore, what does it do? It is going to cause your nitric oxide inhibition. What is nitric oxide? It is a inflammatory mediator. Okay, nitric oxide is an inflammatory mediator. This nitric oxide, also your propanolol, is going to block. It is going to inhibit the nitric oxide pathway, as well as it is going to inhibit your adrenaline and inhibit your noradrenaline. This too also it is going to inhibit. And therefore, we have heart rate which is reduced, pain which is reduced, and thus the action, it reduces your headache. There are 5 mechanisms. What all are they? First, it is going to cause reduce the vasodilation in the brain. Second, serotonin and 5-HT both are reduced, which is going to in turn reduce the inflammation in the brain. Nitric oxide levels, it is going to inhibit that, or it is going to reduce the levels. And then adrenaline, noradrenaline in the tissues, the function of that is also going to be inhibited. So therefore, propanolol is going to act completely different. As we give propanolol for tachycardia, not recommended, but propanolol for headache, always recommended in prophylaxis of migraine. Is it clear?
Yes, it's clear.
Yes, ma'am.
Thank you.
Okay. So I hope there are no doubts now.
No,
Now
ma'am.
coming for different types of headache. See here. If the patient has headache in the frontal lobe, this region, that is going to be the tension headache. If the patient has unilateral throbbing pain, the migraine one. If the patient has headache in the not frontal, but you can say near the orbits and in this region, the sinuses region, it is a sinus headache. Cluster headache is only unilateral retroorbital pain with lacrimation. That is your cluster headache. Then TMJ, bilateral involvement should be there of temporomandibular joint. There is any headache related to the neck, then your frontal and the sides of the neck is everything going to pain. Hormonal headache is overall like the whole head pains generally seen in the postmenopausal woman. And stress headache, again everything is going to pain. Now, okay.
Ma'am, what's the difference between tension and the stress headache?
Telling you. Just allow me some time. All types of headache we are going to see. Don't worry. So this is the migraine headache, which is going to be there in such type of a belt. There is tension headache, a whole full band around the forehead is going to pain. Cluster headache, only the retroorbital region, which is going to the ear, this part is going to be painful. Hypertension, occipital lobe mainly is going to be paining in your hypertensive headache. So primary headaches are what? Either it can be a migraine, tension, cluster, or a hypertension headache. When we talk it as a secondary headache, which are the dangerous ones, which are something which has an underlying pathology. What can it be? It can be your temporal arteritis, subarachnoid hemorrhage, raised intracranial pressure, and your meningitis. So these are everything which is having underlying pathologies. Therefore, they are the secondary headaches or which are not good. It is very dangerous. But the primary headaches, lot of patients you see in the OPD and lot of questions also you see in the exam on primary type of headaches. Now let us see it in detail. Okay, now this is the primary headaches that we are seeing. What is happening in migraine headache? It is going to be a recurrent throbbing, usually unilateral, and it can be having nausea, photophobia, and phonophobia. The duration, which is very important here, of migraine is 4 to 72 hours. Matlab, the patient will come to you 1 day, 2 day, 3 days. 3 days the migraine attack can last in few patients. What are the features? Nausea, photophobia, phonophobia, with or without aura. And the treatments we have to give here is, you have to give the patient triptans. Triptans is indicated. And for maintenance, what will you give? For prophylaxis, propanolol. Okay. And first line acute attack treatment, NSAIDs for a mild migraine and sumatriptan for a moderate to severe migraine. Now, coming to the tension type headache. Tension type headache, the patient is going to complain that it feels as if someone is tied one very tight band around my head. That is going to be a band-like headache without nausea. There is no nausea, there is no photophobia, there is no neurological anything that you see, but only a very tight band is tied around the head. Is this that the patient is going to tell you? Also, there is going to be the 30-minute to lot of days. Even if there is a headache for 8 days, the patient is coming to you. Or he'll say since 14 days. 14 days, my head is paining. It is nothing serious. It is just a tension headache. What is the feature which is there with it? It is a pericranial muscle tenderness that is occurring due to the stress. Again, no CNS deficits are going to be there. Basic paracetamol, basic painkillers, that is your NSAIDs, ibuprofen, ketoprofen, anything you can give for this type of tension headache. Which is the best drug for tension headache? Ideally for headaches, NSAIDs, it is going to be naproxen and paracetamol. Okay. Now, cluster headache. Cluster headache, again unilateral, periorbital, temporal pain with autonomic features. So temporal pain, what it is going to have? It is going to be lacrimation, that is the eye is going to tear, rhinorrhea, nose is going to be blocked, conjunctival injection, the patient is going to come to you with a complaints as if my eye is going to, my eye is paining very badly, my ear is paining, I cannot open my eyes, only one eye, that too, not both the eyes, only one eye is not openable. Such type of headache is a cluster headache. And what is the patient going to be like? He is going to be agitated and he is going to be restless. You will feel it is what it is, just like migraine. But what is the treatment here? High flow oxygen and your subcutaneous sumatriptan. Sumatriptan can be given subcutaneously and high flow oxygen. This generally occurs in the flights. So patients who are having long flights, in the flight pressure cabin and the oxygen levels generally are reduced. So therefore the patients who are having frequent travels, they can have this cluster headache during the flights or any place wherever the O2 levels are dropped. Okay, so any congested area, any place wherever there is too much of crowd, this all cluster headache can occur. Coming to the hypertensive headache, it is due to the markedly elevated BP and with acute target organ effect. So many time, whenever now in hypertension, there is an end organ damage or a target organ damage or there is no end organ damage. Okay, so what is a hypertensive urgency and what is an emergency? Can anyone tell me?
With end organ damage, it's a hypertensive emergency, ma'am.
Okay, and urgency?
Urgency with BP of more than 150/90 without any end organ damage.
Okay, the urgency answer is right, but the BP parameters are not right. Anyone would like to add on this?
More than or equal to 140/90, ma'am?
No.
More than
180.
130.
130.
It's more than
Yes.
130 by. Yeah, more than 130
More
by
than
80.
160 by 100.
The diagnosis come at
It has to be 180
Hypertensive.
by 100 for a
Okay, ma'am, it's on
hypertensive
diagnosis.
urgency or emergency. Okay?
180 by 100, ma'am.
Yes, 180 by 100. Okay? So, yes. Whenever I say that if it is a hypertensive urgency, that means the BP is 180 by 100, but there is no end organ damage. That is going to be a hypertensive urgency. If it is hypertensive emergency, it is always 180 by 100 plus an end organ damage. So, end organ damage, what are the end organs that are likely to be damaged in your hypertension? Can anyone tell me?
heart and kidneys.
Heart, kidneys,
Like
brain,
kidney, heart, brain,
eyes. Okay, so hypertensive
eyes, yes.
retinopathy is also there, right? So all these organs can be damaged. And what is the drug treatment for hypertensive emergency? So one choice of drug.
Nitroglycerin, NTG, labetalol.
Okay, perfect. Labetalol is the drug of choice. IV labetalol should be given. And always remember, the pressure should never come to 120 by 80. In hypertensive urgency or emergency, only 25% of the blood pressure should be reduced. So if it is 180 by 100, in the first 4 hours, you should take it to 160 by 90. Then in the next 4 hours, reduce it to almost 150 by 90. That's it. Do not get it very low. Directly 100 if it happens. More chances of ischemia, more chances of vasoconstrictory damage. Okay?
Okay.
Yeah.
Usually in practice, we give sublingual captopril.
Okay, but according to the books and the guidelines, it is not recommended. It
It's
should be IV labetalol.
ma'am, it's absolute now, sublingual captopril,
Yes, some places
because
they
it's
practice. See,
cask.
yes, right. Perfect. Dr. Abhay, what happens? Globally, we are at a platform. Everywhere, wherever the available resources are, or there are some practices which are designed by the local institutes, they keep on following it. No doubt they are effective, but the only thing what we have to follow on an international level is the guidelines. Okay, so as per the guidelines and as per the book, if you're trying to see the answers as well as in the clinical practice, it is always better you follow the guidelines. And whenever you go outside as clinicians, everyone, if you want to be safe, if you want to be legally right, and if you want to have the maximum effect, good effect on the patients, always follow the guidelines which are given by international associations, because these are the most proven and the most evidence-based practices that we see. Okay? Is it clear?
Yes, ma'am.
Okay. So now coming for the next
Yes,
set
ma'am.
of headaches, that is the secondary type of headaches. In temporal arteritis, subarachnoid hemorrhage, raised ICP, and meningitis, these are all pathological types of headaches. GCA or a temporal arteritis, the age always has to be more than 50, or it is the headache in the elderly, what we call it as. It is going to cause you vision risk. Why? Because the orbital vessels, they are more likely to constrict and they are more likely to be ruptured. So temporal giant cell arteritis or a temporal arteritis, it is a type of medium vessel vasculitis, large vessel vasculitis. Okay. Now what is the associated features with it? It is going to have jaw claudication, visual blurring, and high ESR, high CRP. Why? Because it is a inflammation of the blood vessel. Therefore, it is going to have vasculitis, high ESR, high CRP. What is the treatment of choice? High dose steroids. Immediately give high dose steroids. Methylprednisolone at a dose of 60 milligram orally can be given. Coming to the... Yes, anyone has any doubts? Okay. So, coming to the subarachnoid hemorrhage, what is going to be there in SAH? There is going to be severe headache from aneurysmal bleed. Aneurysm, Berry's aneurysm. So, whenever there is a Berry's aneurysm, it is the worst headache of your life. So, worst headache of the life is your SAH. There is also going to be sign symptoms like meningitis, which is your neck stiffness and vomiting. What you do? You do a CT scan first. If there is a Berry's aneurysm rupture, then what you do?
LP.
No, if there is a Berry's aneurysm rupture.
Okay.
If it is...
then you have to decompress craniotomy.
Yes, you have to do Yes, we have to do the vialing or the coil therapy. That is, we have to immediately stop the bleeding after stabilizing the patient. If the CT is negative, then you do LP. Okay?
Yes, ma'am.
If the CT is positive, don't do LP.
Okay.
Yeah. Then going on for the raised ICP, that is intracranial pressure, this can be due to lot of things. It can be due to tumors, it can be due to the space occupying lesions, it can be due to hydrocephalus. Hydrocephalus, accumulation of the fluid in the cranial cavity. Okay, so these headaches are due to the increased intracranial pressure and they are the worst in the morning and they have BPPV along with it. That is your benign positional progressive vertigo. Okay, now they'll also have vomiting, papilloedema, and it gets worse on the coughing or straining at stools. Why? Because the intracranial pressure is most likely to be raised during this. So, can anyone tell me if the patient has pituitary macroadenoma, is it possible that he'll have the ICP raised headache? If the patient has pituitary macroadenoma, will it
Yes.
cause a raised ICP headache?
Yes, and it will also cause papilledema.
Yes, very good. So the patient will have, because pituitary macroadenoma again is a tumor of the pituitary stalk and it is going to be there causing the ICP to be raised and visual disturbances will also be here. So any CNS disturbances is most likely due to the tumors or any lesions in the brain. What is the treatment here? Urgent CT or MRI and treat the underlying cause. Now coming to the last type of secondary headache that we have, it is going to be meningitis. Meningitis headache, what is there? It is the headache due to the meningeal inflammation. What is the meninges? The covering of the brain and spinal cord. Okay, so the layers. So mainly the spinal cord, whenever it is going to have inflammation around it, we can call it the meningeal inflammation or your meningitis. The signs here: fever, neck stiffness, photophobia. What are the name of the signs that you see in meninges or meningitis? Sorry.
Meningitis.
Cunning signs and Brudzinski signs.
Yes, very good. Very good input. So it is Brudzinski sign and your Kernick sign. These two things, when you try to fold the neck of the patient, that time you try to flex the knee. These signs are elicited by doing this and therefore we have to see whether meningitis is positive or negative. Very nice bedside signs, very commonly asked in your exams also. Now, what is the choice of antibiotic for meningitis? Give antibiotics if you suspect meningitis. What is the choice? One single drug.
Ceftriaxone.
Yes?
Penicillin.
Benzyl
Ceftriaxone.
Benzyl penicillin. Benzyl penicillin. 1.2 lakh international unit is state. First
Ceftriaxone
line.
is the drug of choice for
Ceftriaxone.
meningitis.
Penicillin.
Okay?
Ma'am,
So,
what about the benzyl penicillin?
benzyl penicillin not given these days. Recent guidelines tell you, my dear, ceftriaxone. If you do not have ceftriaxone, give benzyl penicillin.
Okay. Means
Okay?
the in MCQ first choice is ceftriaxone.
Ceftriaxone.
We can also use Cipodexic, no, ma'am?
Cefotaxime, yes, but it can has a lower efficiency. But ceftriaxone is the first. If ceftriaxone not available, go for cefotaxime. Okay?
Yeah. Okay, ma'am.
Yeah. And if you suspect that what type of meningitis it is, what will you do for suspecting different types of meningitis? What is the test to identify?
CSF examination.
Lumbar puncture. Lumbar
Yes,
puncture.
lumbar puncture,
Puncture.
CSF examination.
Yes,
Now, on the
analysis.
CSF examination, you are going to see what are the type of the WBCs, what are the type C. For example, I'll write it here in short. You will see WBC or your lymphocytes. You will see your sugar levels in the CSF. You will see the appearance of the CSF. If it is having a cobweb appearance, what type of meningitis is it?
fungal.
Cobweb appearance. What meningitis?
It's a tubercular meningitis.
Yes, very good. So, if it is having a cobweb appearance, it is tubercular meningitis. You also see for the proteins. If it is bacterial meningitis, then what are the sugars present in the CSF? It is going to rise or it is going to decrease?
Decrease.
Increase or decrease?
Low sugar, because bacteria eat it.
Yes, very good. So there are going to be low sugars. Lymphocytic count is going to be high and the sugar counts is going to be low. There are 5 types of meningitis: fungal, tubercular, viral, bacterial, and another one is the idiopathic one. Okay, clear? Yes. Okay, now just the last slide. What it is? It is going to be the drug of choice during the attack and the drug of choice for prophylaxis. So if it is migraine, during the attack, you give sumatriptan, and long-term management, propanolol or topiramate. Tension headache, during attack, paracetamol, long-term, amitriptyline. What is amitriptyline or nortriptyline? Is it a sedative
It's
or
The
it is a...
tricyclic antidepressants.
Okay,
antidepressant.
very good. So it is a TCA. So basically in tension, we are trying to reduce the stress of the patient. Okay. In cluster, always give O2 and sumatriptan. And for the maintenance for the cluster headache, give verapamil.
Hello.
Verapamil, again, what class of drugs?
It's a calcium channel blocker.
Calcium
Yes.
channel.
Yes, very good. So it is a calcium channel blockers. In GCA, you give steroids, and again afterwards for maintenance of GCA, you give prednisolone at a tapering dose. SAH, the drug of choice for SAH, always asked question, it has to be nimodipine. That is again a calcium channel blocker. And prophylactically, aneurysm treatment. So whatever is the aneurysm, the Berry's aneurysm is outpouching, that we have to treat it. ICP raised, mannitol, always given IV, never given orally, not available orally, not available subcutaneously. Always IV mannitol reduces your ICP, and then treat the underlying cause. For the hypertension headache, IV hypertensive, as I told you, that is your labetalol. And then for the maintenance, give oral antihypertensives. Okay, clear? Is the headaches clear for all of you?
Yes, ma'am.
Yes.
Okay, so I guess due to the less time, I have to shift it on for Dr. Munjal sir, because I already had question for pericarditis, but there is no time. I'll ask sir to take over. Give me a minute. Any doubts anyone has in this CNS things that we did today? The types of headaches, the meningitis, then we did your GBS, myasthenia crisis, botulinum.
Can you repeat why we are not using captopril as first line?
See,
When
captopril is what class, my
sublingual
dear?
captopril.
Okay. So captopril is what class of drug? It is a ACE inhibitors. What is the primary action of ACE inhibitors?
They block the angiotensin converting enzyme.
Okay. And angiotensin converting enzyme, if they are blocking, what pathway are they inhibiting? They are inhibiting the RAS pathway. So in a immediate action of captopril, do you really think that it is going to able to reduce your renin-angiotensin system at a very faster level? No. IV labetalol is very specific. It is cardio-specific, what you can say, cardiogenic type of antihypertensive, which is acting both on your alpha and beta receptors. And if we give it IV, it is going to have 99% of the bioavailability, and therefore IV labetalol is indicated always. If labetalol not available, give NTG, nitroglycerin. Okay, where is sir?
Yes, ma'am.
Yes, sir. I am making you the host. Thank you
No
so much.
problem.
I hope everyone
Wonderful
had...
session, madam.
Yes, you're welcome,
Thank
sir.
you very much, ma'am. Thank you very much. Thank you very much.
Welcome. I
Yes,
guess
please.
who's sir?
Ma'am,
Have I...
excellent explanation and well taken class.
Thank you, everyone. If you're having any doubts, you can post it in the group or post it in the chat for today's lecture. And once you are revising, kindly go through all the mock test. It will be very easier.
Thank you,
Wonderful.
ma'am.
Yeah, too much.
Brilliant.
Yes, sir. Thank you.
Now I have a tough time to take a class.
No, sir, you're always
Service.
the master, but we are trying.
No, no. Now, after having a brilliant session, it is very difficult position for next speaker to, but I am learning from you as well, so that's fine. Great. Just give me a minute. Let the
Yes.
people to settle down for next 1 hour, and I'm literally unstoppable for next 60, 70 minutes. So if you wanna go washroom or something like that, just give your 1 minute. You can go ahead.
Thank you, Dr. Ramya. Also, I guess Dr. Ramya was also a part of us today.
Yes, yes. Dr. Sarini Taj is also joined all the way in the middle of the night from United States. So you are welcome,
Oh,
madam. It's like
how
almost
nice.
3 or 4 o'clock in the
Hi to
4 o'clock.
everyone.
What's the time, ma'am, there now? 4 o'clock in the
So
morning?
it's 3:45 a.m. Yeah.
My God, amazing. So see the commitment, it is more than us. Wonderful. Great. Just give me a minute, ma'am. Everybody
Yes, sir.
get settled down. We'll start, yeah. Madam, Dr. Akanksha, can you make me the host? I cannot share my slides.
Yes, sir. 1 minute. I guess I made a 1 minute. I'll just repeat it again. No, this is
Yes, now it's done.
done.
Yes, please. I can. Can anyone, everybody can see my slides?
Yes, sir. We can see.
Wonderful. So let's start without wasting the time. So I'll always start with the picture MCQ. So this is the first picture in front of you. It's a kind of spot diagnosis. You see, many a times we are getting a picture diagnosis. So this is the picture in front of you. This is lips and the face. You can see the picture, identify what's going wrong with this baby or this young man. So what is your diagnosis? It is psoriasis or eczema, fungal infection, erythema, multiforme, herpes zoster, impetigo. So this is the first questions in front of you, and we have many questions in one question. How you treat, that is what the thing is. How you differentiate all six each from each other, and what causes this condition, right? So just get me the answer of the first question. You can have a chatbot in your computer, so you can post your answer quickly. So I'll go ahead and we can make this very much interactive. Yeah, you can post your answer in the chat box. Yes, please. Anyone? Yes, anyone wants to comment on this? Yes, Dr. Akbar, what do you think this could be a answer, and why I mean you selected the options, and what's how you differentiate from all the other conditions? Yes, please. Yes, anyone? Dr. Rabia wants to comment what it could be and how you differentiate from other conditions?
Mm, Sir, I'm not good. I'm not good enough in skin conditions.
No problem. So you need to little improve. Dr.
This
Sarina Taj, do you have any idea? Yeah, ma'am, please. Sorry.
this honey colored crust is there, golden yellow,
Wonderful.
around the mouth, and there is erythematous oozing lesions are there, and
Okay.
some superficial skin infection is there. So
Okay.
most probably it is impetigo.
Wonderful. Wonderful. So you had given the answer like those who are joining me the first time. Let me tell you, right? The things you need to get three things, right? For any MCQ, you need to have a three things. One is a diagnosis, one is investigation, and third is the treatment. So ask always yourself before answering any question, these three questions to yourself. What is the diagnosis, right? What they are asking here. I'm asking you two more questions. How you supposed to investigate and what's the treatment? So they can ask you anything out of these three questions. This is the 90% of your question is full of these three questions only. So this is by you impetigo, Dr. Anisha. So what causes this impetigo? What causes? You described very well. This is like a honey crusted appearance on the face and labia and perilabial things, right? Which is like absolutely a common sight for impetigo, right? What causes this? Is it bacterial, fungal, viral, parasitic infection, or it's just autoimmune? What do you think? What
It's
it could be?
bacterial infection.
Staphylococcus aureus organic.
Staphylococcus aureus, wonderful. So this is Staphylococcus aureus. And can you tell me, Dr. Anisha, how you differentiate from the eczema? I mean, why this is not eczema? Why not herpes zoster? Any explanation to your mind? I mean, how you supposed to differentiate one from another condition? Fine. So let me take you on the journey of this things, whole thing, so you get better clarity. So this is none other than impetigo. So diagnosis is impetigo. Why this is impetigo? That is most important. Honey colored crust. So if you can see, this is absolutely a honey colored. Honey is looks like this only. Yellow is golden, right? So honey colored crust, perioral distribution. So this is classical perioral, right? Erythematous oozing lesion, common in warm, humid setting, and cause of this impetigo is Staphylococcus aureus, and Streptococcus is also sometimes the culprit for developing the impetigo. Now let's see why not other options and what's the treatment. So treatment of this is very important. It is very common condition, impetigo, especially in children, mild or localized disease like periorbital or perioral. All right, it is mupirocin. If you have heard the name mupirocin, 2% ointment locally, you have to apply 3 times a day for 5 days, or fusidic acid, that is also important, 3 times a day for 5 days, and remove the crust gently before application. So whenever you want to apply locally this medicine, remove the first crust and then you apply this medicine, either mupirocin or fusidic. It is very high yield question in the exam. And if what else, if it is extensive disease or multiple lesion over the face and other parts, then cephalexin, amoxiclavulinate, dicloxacillin. These are the common antibiotic systemic treatment. This is local treatment. This is systemic treatment because it is extensive disease. So you write when the disease is at multiple site, you cannot apply everywhere. So just give the systemic treatment. MRSA, methicillin resistant Staphylococcus aureus, which is major culprit for this. In that case, you can use the clindamycin, doxycycline, and TMP-SMX, that is sulfomethoxazole and trimethoprim. So that's it. This is the treatment as well. So this is the diagnosis is classical. If you see the such picture in your exam, it is none other than impetigo. This is the classical perioral presentation caused by the staphylococcus or streptococcus. It's an infective etiology. Remove the crust and apply locally the mupirocin or fusidic acid and systemic cephalosporin. Now, how you supposed to differentiate from all other conditions? As we seen last time, the few conditions as well. So why it is not a psoriasis? Because psoriasis, as we seen, classical two things you need to remember: silvery scale, usually on the extensor, and odd split sign. That's it. These three things, if you remember, silvery scale, right? It's absolutely looks like a silver, right? Scales, not a honeycomb or golden color scale. It's a silvery scale, usually seen on the extensor surface. Last time we have seen on the external elbow, extensor surface. If it is on the flexor surface, it is a eczema. So this is most important differentiating eczema, flexor surface, flexor surface. This is extensor surface, right? Here in psoriasis, no honey crusted. Here the crusting is serous and not honey colored, usually on the flexor, right? Fungal infection is usually a this is annular lesion, central clearing, not perioral. Like in this case, our case is a perioral, and it is no crust there in fungal infection, right? So either it is tinea corporis, tinea capitis, blah blah. We have seen it right earlier. Erythema multiforme, it is a target-like lesion. So what do you mean by target-like lesion? So this is a lesion, and within lesion there is a target-like lesion. It is also seen in the Lyme's disease. So another target lesion you seen in the Lyme's disease, you can see in the erythema multiformis, right? So it's a target-like lesion. right? So absence of target lesion here in our case, like impetigo, so it is not erythema, and herpes zoster, until proved otherwise, it is a painful vesicle. It is usually in the dermatomes. So either it is in the chest dermatomes, either it is in the abdominal dermatomes, either it is in the nerve dermatomes, right? So these are the common which is usually seen in a immunocompromised patients like leukemia, lymphoma, uncontrolled diabetes mellitus, HIV, an organ transplantation patient, which where you usually see the herpes, or patients on the chemotherapy, where we used to see being hematologist every day, herpes zoster, which is absolutely painful vesicle, right? It is on the dermatomes, and there is a no dermatome patterns here in impetigo. So nothing matching this thing. So it is none other than impetigo. Are you getting me? Yes or no? Are you getting me? Yes or no?
Yes, sir.
Wonderful.
Yes, sir.
Yes, sir.
So we try to evaluate and differentiate all, right? One liner here, how the psoriasis. So psoriasis one liner, extensor surface and silvery scale, which is not here. There is no extensor surface, no silvery scale. Eczema, usually flexor surface. Fungal infections, right? Usually the annular lesion with the central clear area. Erythema multiformis, target-like lesion, right? Herpes zoster, it is a painful vesicle usually seen in the dermatomes. That's it. So this is what the take home message, how you supposed to differentiate one from other. So this is classical impetigo. Treatment of choice is antibiotic. Yes, why? Because it's an infective etiology. So steroid and antifungal at all has a no role. That is a take home message. So if everyone has clear, I'll switch to the next important questions on this platform. Is all clear, I think?
Yes, sir.
Wonderful. So let's start brainstorming your knowledge all to the one of the most commonest condition we see globally is this condition. So first you need to diagnose is what is this conditions is, right? So 35-year-old man with a severe septicemia or sepsis develop acute breathlessness. ABG, that stands for arterial blood gas, shows PaO2 55 millimeter a millimeter of Hg on FiO2 0.8. Chest X-ray shows bilateral diffuse opacity. There is no evidence of heart failure. What is the most likely diagnosis in this case? Is it cardiogenic pulmonary edema, pulmonary embolism, acute respiratory distress syndrome, acute asthma, or acute exacerbation of asthma, or something else which comes up or pop-ups in your mind? So here again, I always start in my practice for last 20 years. I ask three questions when somebody comes to my OPD: what is the diagnosis, investigation, treatment? So my job would be easy. So now they are asking here the diagnosis. So you need to tell me first diagnosis. You need to tell me why not other options are right, not the diagnosis, right? On what basis you made a diagnosis, what point favoring your diagnosis, lots of questions in this, and we'll clarify important issues in this MCQs. Probably we solve 10 question in this MCQ. So let's start and your journey. What do you think? What it could be? What could be the diagnosis here in this case?
It's
Dr.
acute
Serenita,
respiratory
do
distress.
you
ARDS.
think of any condition? One answer is ARDS.
ARDS.
One is ARDS. Yes, doctor. What do you think? What could be the answer?
Acute respiratory distress syndrome, ARDS.
Okay, okay, Del. So this is respiratory distress syndrome. Anyone else? Any other thoughts out of the this ARDS? Any other thought?
Since there is sepsis and there is no cardiac involvement, we can assume that the infection has spread to the lungs as well,
Fair
leading
enough.
to.
Fair enough. Fair enough. Anyone else? So can you tell me, Dr. Abhifida, what is the diagnostic criteria for acute respiratory distress syndrome? So first of all, I need to know these are the questions in front of you now. So let me jump to the next slide. This is the next slide, right? Where we are going to clear all our conceptualized question. Number one question, what is the definition of ARDS? What is the diagnostic criteria of ARDS? What is PaO2? What is FiO2? What is a normal value and interpretation? And how you supposed to treat the ARDS? So if you know this, you can manage any patient in ICU. Believe me, these are the absolutely basic. And if you have concept clarity of these questions, you can save multiple lives. Now you can start, Dr. Bifida, if you want to answer this question, or anybody wants to take leadership and try to answer this question. What is the definition of ARDS? Simple. What is in your mind? Forget about this MCQ. If I can ask you, what is the definition of ARDS? Tell me now.
There is severe inflammation in the lungs, which might lead to alveolar edema and difficulty in breathing, leading to decreased oxygen saturation.
Fair enough. Fair enough. So now, can you tell me, Dr. B, what do you mean by PaO2, number one? We are going conceptualized, right? Your answer is correct. Perfect. Answer is ARDS. Those who have not answered ARDS, they are wrong, right? So just keep in mind, we'll discuss and dissect each and everything in detail in 1 minute. So what is PaO2? What is the full form of PaO2? What is the full form of PiO2?
Partial pressure of oxygen.
Sorry, sir.
Sir, pressure of oxygen. Pressure.
Pressure of oxygen where? Arterial, venous,
Arterial.
or capillary?
Arterial partial pressure of oxygen.
Wonderful. So let's first understand the partial pressure. This is PP, but they mention only one P. That's fine. So partial pressure of oxygen in artery. Is that clear to everyone? Yes or no? Yes or
Yes,
no?
sir.
So this is the pressure of oxygen in arteries. So it is arterial oxygen. What is FiO2?
It's a fractional of inspired oxygen.
Wonderful, brilliant. F for fractionated inspired oxygen. So this is FiO2. So now we are clear. So let's go back to the question. This 35-year-old man with a severe sepsis. So already the sepsis is there. One diagnosis is sepsis. Now he has already the sepsis, and now what happens? He now develop what? Acute breathlessness, right? ABG shows PaO2 is 55. That is partial pressure of oxygen in arteries, and fractionated inspired oxygen is 0.8%, right? This is one thing. Chest X-ray shows bilateral diffuse opacity. So chest X-ray showing bilateral diffuse opacity in the lung, bilateral diffuse opacity. No evidence of heart failure. So nothing to do with the heart. Most likely diagnosis. So forget about the heart conditions. There is no evidence of heart failure. So there is no heart failure means there is a no pulmonary edema. Pulmonary edema develops when there is a heart failure. So A is gone by the simple logic and basic, right? There is nothing to do with the asthma, right? He is not a known case of asthma. In asthma, you cannot see bilateral pulmonary infiltrates. You cannot see, and it is already a case of severe sepsis. So they won't develop the acute exacerbation. Acute exacerbation usually develop in a known COPD or some kind of precipitating factor where they're supposed to develop this. So this is also gone. Pulmonary embolism could be a possibility, right? But pulmonary embolism, right? This is usually where you see the chest X-ray normal. The biggest differentiating point between pulmonary embolism and this condition of acute respiratory distress syndrome. In pulmonary embolism, chest X-ray is absolutely normal. There is a no bilateral pulmonary infiltrate like in ARDS. Is that clear to everyone? Now I will going to dissect whole the questions for a lot of questions. So far, is that clear to everyone? Yes or no? At least you have to tell me yes or no. I expect this much of answer. Yes or
Yes,
no?
sir.
Wonderful.
Excuse me, sir.
Doubt and yes, please.
In pulmonary embolism, there is pulmonary oligomia. Then in chest X-ray, we can see the some findings.
You can see some wedge separated, but this is usually the late stage, sir. Earlier
Yeah.
stage, the pulmonary embolism high yield point, I'll tell you very quickly. Number one, patient has one of the important thing is a risk factor, right? The what has the risk factor? Usually normal walking, talking, healthy patient very rarely develop pulmonary embolism. So either risk factor or precipitating factors are there in more than 90% of the patients. I'm seeing this regular in my OPD being a hemat-oncologist because cancer is one of the important risk factor or precipitating factor. Another is a prolonged immobilization in the bed or hemiplegia. Patient has a lower limb or abdominopelvic surgery, right? Patient has a thrombophilia. Thrombophilia. What do you mean by thrombophilia? So condition in which the blood is hypercoagulable, right? So maybe polycythemia vera, chronic myeloid leukemia, essential thrombocytosis, protein C, protein S deficiency, right? Lupus anticoagulant. These are the conditions where it is called thrombophilia, right? So these are the commonest predisposing factor for pulmonary embolism. So if somebody tells you normal healthy individual develop breathlessness, very rarely it has a pulmonary embolism. This is clinical tips I'm giving you honestly. So this is precipitating factor. Even though you are thinking pulmonary embolism, the beauty is that this is high yield point I'm telling you. If you can write down, it would be great. Not in the books specific. Chest X-ray is normal. Another beauty is lung examination is absolutely normal. No crepitation, no hyperresonant, no dull, bilateral equal air entry. Absolutely lung examination is normal. Another thing is a heart examination is normal. Another exam high yield point. There are three changes in the ECG which is asked frequently in exam. What is the most commonest ECG finding see you in pulmonary embolism? Write down the answer is sinus tachycardia, which is one of the most commonest finding seen in pulmonary embolism. What is the pathognomonic features of ECG of pulmonary embolism? It is S1Q3T3.
S1Q3T3.
Wonderful, brilliant. So S wave in lead 1, Q wave in lead 3, and T wave in lead 3 is this. And third question in exam, what is the most non-specific T wave changes in ECG is T wave inversion, T wave inversion. So these three are all three different exam questions. ECG most common, sinus tachycardia. Pathognomonic for pulmonary embolism in ECG, S1Q3T3. Most specific, non-specific changes in ECG is T inversion. That's it. So this is nothing is there in our scenario. Now go and match it. Are you going to see anything what I explained you? And one of the most important, the high yield, these things diagnostic is pulmonary angiogram is the most important test. Pulmonary angiogram, one of the most highest sensitive and specific test to diagnose pulmonary embolism. So now explaining all these things out of the box from these questions, is that clear to you, doctor, what you asked me for the pulmonary embolism or not yet?
Yeah. Yes, sir. Thank you.
Wonderful, brilliant. Should I go ahead or not?
Yes, sir.
Wonderful, brilliant. So this is what the thing is. So now let's get the answer of these questions. So let's jump to the normal value of PaO2, right? PaO2, right? A means arterial, P means pressure, O means oxygen, and two atoms of oxygen, right? Dioxide. So partial pressure of arterial oxygen normal is 80 to 100. You just need to remember small numbers, 80 to 100 on room air in a healthy individual. What is right? So two things. What is PO2? This is PO2. What is the normal range? This is the normal range. Second comes to second thing, FiO2, fractions of inspired oxygen. Fraction F inspired oxygen. That's it. Fraction of inspired oxygen, FiO2, right? It is room air. What is the normal room air? 21%, right? So this is normal is PaO2 is 80 to 100 and this is 21%, right? And what is the normal ratio? Normal individual, if somebody does your PaO2 and FiO2, what should be the normal? So anything more than 300 is normal ratio, right? So PaO2 divided by FiO2, PaO2 divided by FiO2 ratio normal. So remember just normal oxygenation more than 300. That's it. What if it is less than 300, sir? Then so 300 to 200 is mild, 200 to 100 is moderate, and anything less than 100 is a severe acute respiratory distress syndrome. That is what mild, moderate, severe, less than 300. So far clear? Yes or no? At least tell me yes or no. It is very important and basic. If you don't understand, it's difficult. If you understand, you can answer any question. Is that clear to everyone? Yes or no?
Yes, sir.
Yes.
Wonderful. Let's
Yes, sir.
jump to the little next understanding. ARDS now definition. So why this is ARDS? Why not other? We'll see why not other. Also we will see. But first see why these are the answer. ARDS. So severe sepsis, the most common precipitating cause of ARDS globally. So whenever ARDS doesn't develop again without, predisposing, there are long list of ARDS, right? So we'll see it. But one of the most common is the infection, severe septicemia or sepsis, right, which affects the lung and do all the cascade of ARDS. So this is the one of the. So what is the one of the most common cause of ARDS? Severe sepsis. You need to remember this. How they present acute onset of breathlessness. How you supposed to diagnose? By the ratio. I told you more than 300 is normal. What is the ratio here? Our PaO2 is 55, right? And FiO2 is 0.8. So go and do the calculators. 0.8 is equal to somewhere 69. And anything less than 100, 300 more than 300 normal, 300 to 200 mild, 200 to 100 moderate, and less than 100 is severe. Are you getting me? Yes or no?
Yes, sir.
So this is severe
Yes,
hypoxemia.
sir.
We calculated, clear cut. We calculated. So now cause is clear. How they present clear. How you supposed to calculate PaO2 dash FiO2. They usually have bilateral diffuse opacity on chest X-ray. Yes, we do have, and no evidence of cardiac failure. So we have everything. We have septicemia. Now let's go back and see whether severe septicemia, acute breathlessness, FiO2, and this and uh, this bilateral chest opacity and no cardiac failure. Is it there or not? Everything is there in our scenario. Let's confirm. Let's confirm. Then you get more clarity. We are not in hurry. Severe septicemia, yes, number one cause. Patient usually present with acute breathlessness, yes. Patient has a ratio of less than 100 super severe or severe acute respiratory distress syndrome, yes. Number three criteria. Patient has bilateral chest opacity, yes. Patient has no evidence of cardiac failure, yes. Five. We have everything. It is none other than ARDS. Are you getting me?
Yes, sir.
So now I
Yes,
think
sir.
this slide is absolutely clear cut. If anybody has doubt, I'll stop for 5 seconds. If no, I'll go ahead. Fair enough. No doubt. Why not other? Let's see. That is also our job, na? Sir, you explained very well why this, not other. Cardiogenic pulmonary embolism was B options. So it is not there. Why? Because there is no in pulmonary edema, cardiogenic pulmonary edema. There is a raised pulmonary capillary wedge pressure, which is not there. They you would usually have right ventricular failure, edema, pedal edema, blah blah. Nothing is there. Pulmonary embolism usually clear X-ray or focal changes. Right here we have bilateral opacity, which is not there. So it is not pulmonary embolism. And in acute exacerbation, hyperinflation, there must be wheezing or no diffuse opacity. No diffuse. We have diffuse opacity in the lung on both the lung. So this all excluded. So this is none other than ARDS. So what is my take home message for this condition is one liner. If you don't remember whole the story, one line, right? If you remember this one line, you can answer all ARDS. Look for the sepsis, one of the most common case. Look for the bilateral infiltrates in the lung. Look for the severe hypoxia. How you supposed to do? Partial oxygen pressure in artery divided by fractionated inhaled oxygen. If it is more than 300, it is normal. Anything less than 300 is ARDS, and this could be categorized simply in mild, moderate, and severe. That's it. That's it. And a normal heart. Fourth is a normal heart.
Perfect.
Normal heart. This is ARDS. Any confusion? Any confusion?
No, sir.
Brilliant. Now comes to the take home message. For you, take home message. How you supposed to? All must be present. All must be present. So this is Berlin criteria for ARDS. Timing. What's important is timing. Within 1 week of known clinical insult. So septicemia developed today on 25th, and within 1 week of time within 1 week or first of the Feb, he developed the acute respiratory distress syndrome, acute shortness of breath, bilateral chest infiltrate, PaO2 by FiO2 is less than 300, right? There is no cardiac condition underlying, no heart failure, no IHD, nothing. Patient absolutely fine, ARDS. Within 1 week of known clinical insult, anything. One of the most common is septicemia. New or worsening respiratory symptoms, which is not there at the time of admission. At the time of admission, she was fine, but within 1 week of time, they developed this, and this is now ARDS. So this is precipitating factor common is ARDS, right? Chest imaging, bilateral opacity should be there. So one criteria, look for the time how they develop. If somebody develop after 2 months, it is not ARDS, it is something else. Think of something else. Within 1 week, usually within 1 week, they usually develop. Chest imaging, bilateral opacities either on the chest X-ray or CT scan, right? So this is also important, right? Third thing is also important. We are trying to get the diagnosis. So one time is important. Chest X-ray is important. Third thing is origin of edema. It is respiratory origin, right? Not cardiac origin, not cardiac origin, right? And this is the PaO2 by FiO2. I already told you mild, moderate, and severe. So that's it. What are the high yield pulse for this question? Most common cause of ARDS is sepsis. Pathology is increased alveolar capillary permeability, right? Severe ARDS, right? So this is severe ARDS. That's two things are not much important for you. So that's it. This is what the thing is. And last slide for today for this question, right? If you don't remember, remember this TIOO. What do you mean by sir TIO? Timing. So once you have, right, within 1 week of time, 1 week of time of septicemia or lung injury or lung insult, they develop acute breathlessness. FiO2 is reduced to 300 below, plus bilateral pulmonary infiltrates, no cardiac origin. Timing is important. Infiltrates bilaterally, that is I. So time, bilateral infiltrates, origin should be non-cardiac, right? And oxygen is impaired. So this is the definition of ARDS in short. So that's all from my side for this question. And treatment. Treatment, I told you what is the treatment. So let me ask you treatment, treat the underlying cause, treat the hypoxia, treat the sepsis, give the antibiotic as per the culture, as per the x-rays, whatever the you can do the BAL or bronchoscopy or sputum or gram stain, whatever comes, you can treat accordingly. So treat primary underlying conditions of this ARDS, right? So that's all from my side for these questions. I think I tried my level best to get you the journey of all the questions of
Sir,
ARDS. Is that clear to
sir, I
everyone? Yes
want
or
to
no?
say, sir, I want to say that in this scenario, treatment is just mechanical ventilation only.
Not mechanical ventilation upfrontly, right? This patient has acute respiratory distress syndrome. So you just try to first support with the oxygen, BiPAP, and then ventilation. So ventilator or mechanical ventilator would be the last option in any patient. You can't put until and unless very severe. This is severe. So try to give the BiPAP support to this patient. Try to treat the underlying condition which precipitate the ARDS. So primary culprit is not the lung. Primary culprit is the septicemia. So try to control the septicemia. Along same time, you try to support the respiratory system as well. So in any condition, as you know, ABC is there, right? Airway, breathing, circulation, blah blah. So this is for everything, isn't it? So you need this goes hand in hand, right? You can take care of respiratory things. You can take care of this. So try to support with the BiPAP or SOS then ventilator for sure.
Okay, thank you.
Yes, please. Should I go ahead? Is that clear?
Yes, yes.
Yes,
Yes.
sir, yes, sir.
Dr. Akanksha, am I going well? Wonderful. So let me jump to the next question. So this is very important. I mean, there is no ICU globally who does not have this ARDS patient. Every other patient is ARDS. So we need to understand the basics of ARDS. So I thought let me include this question. So it's very important. and it is life saving as well. So pick up its ARDS is as good as acute myocardial infarction. If you don't treat and promptly treat on time, they may die because of respiratory failure. So that's it from my side. Let's jump to the another my favorite team oncology. So there, my HB is increased after seeing this MCQ. So let me discuss this. Most common non-Hodgkin's lymphoma worldwide: follicular lymphoma, mantle cell lymphoma, diffuse large B cell lymphoma, marginal zone lymphoma. This is one question. There are hundreds of questions which I read on behalf of you. What is lymphoma? How you differentiate Hodgkin's from non-Hodgkin's? How you differentiate all the lymphoma given in the option A, B, C, D? How you differentiate one from another in terms of age, clinical features, histology, ISE, immunohistochemistry, treatment, blah blah, hundreds of questions. What is the initial treatment of non-Hodgkin's? We are talking about non-Hodgkin's. So, what's the treatment of non-Hodgkin's lymphoma? So now you can start your putting the answer in the chat box. And if somebody is good enough in oncology or lymphomas, I would be happy. You can interact with me directly. Yes, please. So we are 30, 40 doctors in the class, but unfortunately we are getting only few questions, answers. Why? I don't know. Yes, please. Dr. Safni, can you interact with me, or Dr. Helena? Would you like to comment on this? I would like to hear from you. Dr. Shafni, any comment from your side? Any Joseph, Serena, Taj? How is your experience in United States? What lymphoma you see the most, non-Hodgkin's lymphoma?
Doctor, so far nothing over here at our side where I'm working.
Fair enough.
Because we don't receive cancer patients over here. They go to a different healthcare facility.
Fair enough. Fair enough. Fair enough. But just keep the answer in mind, because this is exam point of view. I mean, whether we see it or not, we need to answer in the exam, isn't it? Yeah. So just for the answer, just yes. Anyone wants to comment on any of this? First of all, the A, B, C, D, E. Any volunteer, Dr. Rajesh Radhan, any comment? Yeah, you can speak up, na? Don't worry about right or wrong. It's all absolutely a learning platform. Don't shy. Speak up. Yes, please. No one. Dr. Shahnaz. Yeah,
The
madam.
non-Hodgkin lymphomas are more common as compared to the Hodgkin's lymphoma. And Hodgkin's lymphoma, they usually go in a predictable fashion, while non-Hodgkin's are more, they're more severe.
So what is the answer here? First of all, what is the answer here by your, experience or anything you heard of this?
So I've only heard of diffuse large B-cell lymphoma.
Fine.
So
So do
that's
you
why.
think this is the most common globally?
Yes, because I've
Fair
not
enough.
heard
Fair
of
enough.
the
Fair enough. Fair enough. Fair enough. If I can ask you, this is one question, right? Most common is different issue. So you told diffuse large B-cell lymphoma. Fair enough. Right? I'll ask you, right? Amongst this, which has a which lymphoma has a very good prognosis? Answer could be same, it could be different.
It is the same. It's very
It is
treatable.
the same. It is very much treatable. DLBCL. We call in our medical hemato-oncology term diffuse large B-cell lymphoma. So this is DLBCL. Fair enough. What is the treatment of choice for this DLBCL? That is also again, here the things. Initial treatment. So if you have a DLBCL, what could be the treatment? How you supposed to treat? You do surgery, you give radiation therapy, you give monoclonal antibody, you give immunotherapy, you give CAR T cell therapy, you do bone marrow biopsies, or you do chemotherapy. Lots of options I had given you. Yes, anyone? Fine. So let me start my lecture and try to clarify all the concepts related with the lymphoma. So lymphoma, the basic definition of lymphoma is a malignancy. It is a malignant tumor of lymphoid tissue, simple lymphoid tissue. Where is the lymphoid tissue? Lymph node. It could, commonest site is lymph node. Then skin, right? It could be in the GI tract. It could be in a primary CNS lymphoma and extranodal sites, spleen, bone marrow, blah, blah. So wherever the lymphoid tissues are there in the body, you can get lymphoma. That's it. This is a this is a malignancy of lymphoid tissue. It could be in the thymus as well. Thymus is also a lymphoid organ, right? So this is lymphoma. Now let me give you the super duper differentiating point for lymphoma. Will you, even if you wish to forget, you cannot forget, right? This is my primary subject. Being a hemat-oncologist, I'll make it very simple and crystal clear for you. So this is the answer is diffuse large B-cell lymphoma is the most common NHL worldwide. What is lymphoma? Lymphoma is malignant tumor of lymphoid cells. Again, question, what are the lymphoid cells? So B lymphocyte, T lymphocyte, and natural killer cell, right, involving lymph node. The most common is site, then bone marrow, and extranodal, nodal, and then extranodal. What are the extranodal? Gastrointestinal, skin, CNS, I already told you. So this is the thing. Now let's come and jump to the how you supposed to differentiate from the Hodgkins from non-Hodgkins. So this is absolutely a crystal clear picture. I got it for you guys. So just concentrate and look into the picture. So Hodgkin's lymphoma, the most important thing for Hodgkin's lymphoma is RSL. What do you mean by, sir, RSL? It is a Mr. Reed and Mr. Sternberg. So Reed Sternberg cell. It is the name of the people. Reed and Mr. Reed, Mr. Sternberg, RSL. Right. So what is RSL present? What do you mean by, sir, RSL? How it looks like RSL? So this is looks like this. Right. So it is all eye. If you can see, this is all eye. This is all eye. And if I can draw this, this is all. Is that clear to everyone? Yes or no? So
Yes,
if
sir.
this cells you can
Yes.
see under the microscope of any biopsy, either excisional lymph node biopsy, bone marrow biopsy, or any suspected site lymphoma this lymphoma biopsy, if you see this cell, it is none other than Hodgkin's lymphoma. So this is depend. This is the one of the most primary classification histologically. So any lymphoma, you need to ask number one question: RS cells is seen or not? If the RSL is seen, it is Hodgkin's lymphoma. RSL is not seen, non-Hodgkin's lymphoma. That's it. This is primary point of differentiating Hodgkin's from non-Hodgkin's. Let's jump to the another things. So RSL present Hodgkin's lymphoma, RSL absent non-Hodgkin's. So this is picture of RS. So it is Hodgkin's because Reed Sternberg cell is cell. I want you to show how looks like. That is why I kept this picture. And sometimes they gives you as a picture MCQ spot diagnosis. Identify what is the diagnosis. Hodgkin's lymphoma, non-Hodgkin's lymphoma, AML, ALL, CML, CLL. Six option. Answer is Hodgkin's lymphoma. Reed Sternberg cells in only in Hodgkin's lymphoma. No hematological malignancy. Second spread is contagious spread. What do you mean by contagious? So say for example, this is a neck part, right? So in neck, it is a cervical lymphadenopathy. It is in a one distribution, contagious, right? From one level 1, 2, 3, 4, 5 in the neck, right? While non-Hodgkin's lymphoma is widespread, non-contagious, it could be in the neck, it could be in the chest, it could be in the iliac, it could be para-aortic, it could be carinal, blah blah. So it's widespread. It is non-contagious. Extranodal is very rare. They don't usually go out of the lymph node. It is absolutely a common. Let me tell you one more thing. Usually they diagnose in stage 1 and 2. Here they usually diagnosed in stage 3 and 4. So it is widespread, more aggressive, more non-contagious. RS cells are absent. B symptoms are common. What do you mean by B symptoms? Can anyone tell me B symptoms? Can anyone tell me B symptoms? What is B symptoms? Have you heard of B symptoms? Yes or no? At least tell me yes or no. Anyone? No one? I don't think so. It's so difficult question for you guys because you are answering a
There is
lot more
fever.
complicated.
Presence of fever.
Okay, so three things remember. One is fever, right? Another is night sweat, and weight loss. Weight loss, more than 5% of weight loss from baseline weight. This is three symptoms. So if somebody present with these symptoms, it is B symptoms positive. If somebody does not have, somebody has no fever, no night sweat, no weight loss, no B symptoms. What is the importance of B symptoms? B symptoms, presence of B symptoms is poor prognostic factor. So if somebody has a fever, somebody has a night sweat, somebody has a weight loss, means Hodgkin's lymphoma with B symptoms, poor prognosis. Hodgkin's lymphoma with no B symptoms, little better prognosis. So it is not just simply put it in the chart. It has excellent prognostic importance. That is why it is in the chart. Right? So here B symptoms is common, here less common. That does not mean it is absent. It is, say for example, this is 3 plus, this is 1 or 2 plus. So both can be present in both, but it is more common than this. Mediastinal mass is common, right? And here is uncommon. Prognosis is better compared with non-Hodgkin's lymphoma, here variable, but it is more aggressive than Hodgkin's lymphoma. So overall prognosis compared with Hodgkin's lymphoma is poor, but still it is curable. So I think this is very simple head-to-head comparison of Hodgkin's versus non-Hodgkin's. You must remember this, how the red Sternberg cell seen, spread, extranodal site, these symptoms, mediastinal mass, and prognosis, right? So it is very important and little more go in detail, right? Looks you guys little boring, but it's important by my sense. So follicular lymphoma, it is indolent lymphoma, right? So lymphoma classification, you're supposed to classify. Sorry for giving a bit more in depth. One classification is Reed-Sternberg cell. If present, Hodgkin's lymphoma. If absent, non-Hodgkin's lymphoma. So presence or absence of RS cell. This is one classification. How fast this spread? What is the speed of the spread, right? So if the speed is slow, it is called as indolent. Indolent. So speed. Aggressive lymphoma. Indolent and aggressive. This is how it mentioned in the book. Aggressive lymphoma, indolent lymphoma, slow growing lymphoma. Which are the indolent lymphoma? Follicular lymphoma is an indolent lymphoma, slow growing lymphoma, right? It is common, but not as common as diffuse large B cell lymphoma, right? So it is second most common. First most common is diffuse. What we see in our practice for more than 2 decades by histology. Second is follicular lymphoma. So follicular is indolent. This is aggressive lymphoma, aggressive lymphoma, aggressive lymphoma. So if somebody asks you what is the example of indolent lymphoma, follicular lymphoma, aggressive lymphoma, diffuse large B cell lymphoma, it is aggressive lymphoma because it spreads slow, it spread fast. That's it. There is no rocket science, right? And what abnormalities you can see? Translocation 1418 and BCL2 you see, right, in the molecular studies. And this is aggressive, rapidly growing, fast growing tumor, but it is one of the most common NHL. What is the question in our MCQ, right? So most common non-Hodgkin's lymphoma is diffuse large B cell lymphoma, and two other are also there is a, just for your kind knowledge, there are more than 60 plus kind of lymphoma, right? If you go and open up the WHO classification of non-Hodgkin's lymphoma, I just mentioned four. There are more 50 plus lymphomas are there, but I'm trying to discuss you the common one, and I don't want you to sleep by discussing the lymphomas all. If you guys are interested, I'll take one dedicated lecture for lymphoma as well. So this is the most common, and the treatment is very very important. The RCHOP is global treatment for non-Hodgkin's DLBCL. This is treatment for diffuse large B cell lymphoma, right? And which is also called as a CD20 positive. If you see the lymph node biopsy and you do the IS immunohistochemistry, CD20, that is surface marker. So this is a cell and this is CD marker, cluster differentiation presented on the cell surface. So this is CD20 positive. If it is present, it is positive, CD20 negative, CD20 negative. So The cell which is CD20 positive, there is one monoclonal antibody. Wherever a MAB comes, MAB comes, rituximab, MAB means monoclonal antibody, for your kind knowledge. Whenever the MAB comes in the suffix, it is monoclonal antibody, so antibody comes against this. So rituximab you can give in any condition where the CD20 is positive. So this DLBCL is a B cell lymphoma and CD20 is a marker of B cell lymphoma. So if it is present, you give the rituximab. If CD20 negative, just give the CHOP, not R, because CD20 negative. But most of them, they are positive. So we usually give R-CHOP. So R stands for rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. It's a steroid. So this is a cornerstone of the treatment world over. Even I going to US for our ASCO meeting, discussing a lot of things in Chicago in ASCO, American Society of Clinical Oncology, happens every June, July in Chicago, Illinois. So we discuss this all, how you treat in US all. So this is all the same treatment globally as per the NCCN guideline. National Comprehensive Cancer Network is largest oncology body globally. So they have a guideline. Just for your kind knowledge, the guideline name is NCCN, National Comprehensive Cancer Network US. But there are hundreds of countries is member of NCCN. They make the guideline, and this is the guideline now. R-CHOP is a first line treatment for diffuse large B cell lymphoma. And before closing this lymphoma lecture, doxorubicin side effect, most important side effect is cardiotoxicity, and that is why whenever we start, we do a 2D echo baseline. 2D echo we do a baseline just to know the ejection fraction and pulmonary artery hypertension. That's it. The two things we need to know before starting doxorubicin. It's cardiotoxic drug. So we just going to see by 2D echo these two things. Vincristine is usually causes peripheral neuropathy, and many patients of DLBCL, they have diabetes mellitus. So we need to take care of good care of diabetes plus neuropathy, because steroid prednisolone again worsen the diabetes. So those patients who have NHL, DLBCL plus diabetes, chronic, uncontrolled, we need to take care, utmost care of peripheral neuropathy. We give pregabalin, we give methylcobalamin, we give neurotonic to reduce the risk incidence of peripheral neuropathy. Cyclophosphamide, myelosuppression, so baseline complete blood count or full blood count could be important, right? Because if we did not did baseline, we exactly don't know how much the myelosuppression happen. And rituximab can cause infusion reaction or anaphylaxis. So drug of choice for anaphylaxis is epinephrine. So you must keep in mind this drug, life-saving drug for anaphylactic shock. So these are the common side effects which usually they ask in the exam. What test you supposed to do before starting the R-CHOP, right? So for doxorubicin, cardiotoxicity, 2D echo, diabetes control, neurotonics, here the baseline CBC, and you just keep a watch on the anaphylaxis because of bad infusion reaction, because rituximab is a foreign factory made, chemical made protein, right, which are going to be infused in the body. So there is a high risk of developing the rituximab. So it's a culprit. So you need to keep watch on this. So that's all from my side for non-Hodgkin's lymphoma. And probably the last questions, if you allow me, I can continue. If you are tired, I can stop it here. So your consent is important. Should I go ahead
Please
for one more
continue.
question?
Yes,
Yes
sir.
or no? Wonderful. So is that clear to everyone? Does anybody has any questions of lymphoma? Any questions of lymphoma? Not this MCQ only. Any things which is not clear for many years? It's a golden opportunity to ask. Yes. If you don't ask, I consider you knows all well. So I'll go ahead. Yes. Anyone?
Sir, no doubt you are a very good hematologist. But what is our limit? What is our limit for DHA exam to read out the lymphomas? To learn
Enough.
lymphoma
This is enough. If you understand
for
this
PROMETRIC exam.
for PROMETRIC, this is enough.
This is enough, sir?
Yeah, this is enough. Nah, I told you the basic. If you have any question in your mind, I would be happy to answer any of your random questions. Yes. Fair enough. So you go and read it, lymphoma, Hodgkin's, non-Hodgkin's. If you come across any questions, just get back to me. And I have two more questions to discuss, but I'll discuss one. Probably you all guys are hungry. So I have few more questions, but this is last for you. So just bear with me one more questions, which is really interesting and very common. Bit long MCQ, but don't scared of long MCQ. I'll give you the tips and tricks how to dissect the long MCQ in short MCQ. So 24-year-old male present to the outpatient department with progressive fatigue, breathlessness on exertion, recurrent infection for the past 2 months of bleeding gums and easy bruising over last 2 weeks. There is no history of fever, weight loss, means no fever, no weight loss, no night sweat, no bone pain. He denies joint pain or rash, no history of chronic illness. On further questioning, he gives history of recent exposure to pesticide, which is working on a farm. He is not on any chemotherapy. There is no history of radiation exposure, no family history of blood disorder. So this is a clinical history. What's the examination? Patient is pallor. Patient has a patechi and ecchymosis present. Patient has no lymphadenopathy in cervical, axillary or inguinal region. There is no hepatosplenomegaly on abdominal examination. His absolutely vitals are stable. You did some blood investigation and blood investigation shows this. Hemoglobin of 6.8, white cell count of 2000 per cubic millimeter, platelet counts are 25,000, reticulocyte count is low, peripheral smear shows pancytopenia, normochromic normocytic red blood cells, no blast in the peripheral smear. Bone marrow examination is also done for this patient. Shows hypocellular marrow, marked reduction in hematopoietic cells, fatty infiltration, no fibrosis, no malignant cells. What is the diagnosis of this patient? Is it acute myeloid leukemia? Is it acute lymphoid leukemia? Is it multiple myeloma? Is it aplastic anemia? Is it myelodysplastic syndrome? How you differ all the options one from another, right? So this is the questions. So if you don't forget this, this is the questions. If you want to ask me some more questions or detail, I can provide you for this patient. But this is history. This is the history and examination. This is the investigation, and what is the diagnosis. So there is a 3 slide for one question. History, examination, investigation, what's the diagnosis. Any volunteer? Last questions for today. Just bear with me 5 minutes. You're all leukemia, lymphoma, myeloma, aplastic, and MDS. I'm gonna guide you all 5 things in next 5 minutes. Complete crystal clear idea about all 5 things, which looks very tricky and difficult now, but in next 5 minutes, lots of clarity. Believe me. Yes.
All the cells are decreased, so this goes towards aplastic anemia.
Wonderful. Aplastic anemia. Brilliant. So now tell me what point favoring the aplastic anemia in this patient. You have history, examination, and lab. I'm saying this is acute myeloid leukemia, severe pancytopenia. So why it is not acute myeloid leukemia? Just for our learning purpose, we are discussing little bit things. So why it is aplastic anemia? Why not acute myeloid leukemia?
Because in acute myeloid leukemia, there will be increased in the leukocyte count, but they are decreased as well. And
So
reticulocyte count is low. So
fair enough. So
also
just
in the
1 minute.
bone marrow
Sorry to interrupt you.
biopsy,
Sorry to interrupt you. 1 minute. The presentation of acute myeloid leukemia could be this. I mean, WBC or total count, you open up the book. The most commonest presentation of acute myeloid leukemia is low count. Second is increased count. And third, it could be a normal count. I did more than 3,000 bone marrow biopsies so far in my practice. And I come to the conclusion and I read many literature, right? It has a variable presentation. So let me give you one example of acute myeloid leukemia for just understanding. It is very important. Hemoglobin, white blood cell count, and platelet count. So one scenario is this: hemoglobin is 8, white blood cell count is 2000, and platelet count is 50,000. Say for example, this is one case where the WBC is low. Rest thing is same. Hemoglobin is 8, WBC is 5,000, means normal, and platelet is 50,000. And third scenario, hemoglobin is 8, WBC is 50,000 year high, and platelet is 50,000. So even with the low, normal or high WBC, acute myeloid leukemia can be possible. Just for your understanding. Are you getting my question? Yes or no?
Yes, sir.
Wonderful. Now you go ahead. I'm just trying to make you understand, right, what can be clinically present. So it is not mandatorily that the WBC count should be high in acute myeloid leukemia. That is my take-home message. It 100 out 80 out of 100, what I see in my practice for last 20 years is low count. 50-20% is high count and very rarely normal count, but it can be possible. I have recently diagnosed one patient who has the same scenario, normal WBC count, but he turned it to be acute myeloid leukemia. So what we are discussing here, why it is aplastic anemia, why not acute myeloid leukemia? Now you can go ahead. Sorry to bother you in between.
So there is also pancytopenia on peripheral smear, and there is marked reduction in hematopoietic cells in bone marrow biopsy.
So pancytopenia, that is PCP in short, it is here pancytopenia, here also pancytopenia. So how you differentiate? What are the differences? Sorry, sir.
Peripheral
No
smear.
blast. No blast.
So what you see in peripheral smear in aplastic anemia, what you see in peripheral smear in acute myeloid leukemia. Now you tell me. I'll tell you everything in next 5 minutes, but I want to understand your concept. Yes, tell me. Anybody wants to try?
Acute leukemia, there is more than 20% of blast cells.
Brilliant, super brilliant answer. Super. So number of the blast cell is the main hallmark which differentiate any leukemias, acute myeloid. I'll give you the basic. So there is a no blast cell in acute myeloid leukemia. Oh, sorry, aplastic anemia. No increase in the blast cell. Normal blast cell is 2 to 5% or less than 2 to 5%, which is normal. Anything more than 20% of the blast cell is acute leukemia. So acute leukemia, you go and see my hematology dedicated lecture. All leukemias is given very transparent, clear cut on our YouTube channel. I already shared you the link. If you don't have, just drop me message on this. I will share the dedicated hematology. So acute leukemia, the international definition of WHO is more than 20% of blast. Now, how you it differentiate acute leukemia? There are two variety: acute myeloid leukemia, acute lymphoid leukemia. Here 20% blast, here 20% blast. But here myeloblast, here myeloblast, here lymphoblast. That's it. This is different. So if you have more than 20% of the lymphoblast in blood or bone marrow, it is acute lymphoid leukemia. If you have more than 20% of myeloblast in peripheral blood or bone marrow, is acute myeloid leukemia. So your first job by doing the bone marrow biopsy is to find out how much is the blast. 20%, more than 20%. Now it is acute leukemia, right? If the morphologically it is myeloblast, it is acute leukemia. If it is morphologically lymphoid blast, it is acute lymphoid leukemia. That's it. Both have 20% plus blast. That's it. So there is no blast, no blast, no blast, no blast, no blast, means leukemia is gone. So AML is gone from our list. ALL is also gone from our list. Are you getting me? Everybody is getting me? Yes or no? At least tell me yes or no.
Yes, sir.
Wonderful. So what was the options? What was the options? So acute myeloid leukemia, right? It is gone. Why it is gone? No blast. What we need to diagnose AML? More than 20% myeloblast. Acute lymphoblastic leukemia gone. Why? Because there is no blast, no 20% blast. If it is there, more than 20% blast, but lymphoblast. So this is gone. This is gone. What is a multiple myeloma? What is multiple myeloma? What happens in multiple myeloma? There is a plasma cell, increase in the plasma cell more than 10%. Don't get confused between leukemia and plasma cell. In leukemia, more than 20% blast cell, which is called the premature cell. it is 20%. Myeloma, 10%. Don't get confused. Not a 20% plasma cell, more than 10% of the plasma cell, right? It is a plasma cell, right? Monoclonal plasma cell, right? If it is seen in the bone marrow, so in bone marrow, they have not mentioned plasma cell. Let's go back and see the scenario. Did they mention the plasma cell in examination? So bone marrow biopsy is hypocellular. Bone marrow biopsy is hypocellular. Marked reduction in hematopoietic, no fatty infiltration, no fibrosis, no malignant cell, no plasma cell. Not mentioned means absent, no plasma cell. So there is no plasma cell. One of the best diagnostic tool for multiple myeloma, if they ask you in the exam, what are the most sensitive and specific tests to diagnose multiple myeloma? Answer is bone marrow biopsy. No serum protein electrophoresis, no free light chain assay, no urinary free light chain assay, no Benz-Jones protein, no skeletal survey, nothing. The most sensitive and specific diagnostic test for multiple myeloma is bone marrow examination, which supposed to see more than 10% of abnormal looking monoclonal plasma cell in blood or bone marrow. This is the definition of multiple myeloma. So three things are gone already here as by my explanation, right? Acute myeloid gone, acute lymphoid gone, multiple myeloma gone. And now you have two options, aplastic anemia and myelodysplastic syndrome. So myelodysplastic syndrome, what you can see in myelodysplastic syndrome, how you differentiate from leukemia. So in leukemia, more than 20% of blast cell, here less than 10% of blast cell. All cells are dysplastic. If you see morphologically dysplastic, neutrophil abnormal, this means abnormal, plastic means plasia. So dysplasia means it is an abnormal size shape, right? Dysplasia. So dysplastic RBC, dysplastic WBC, dysplastic platelet. So either there is a mono nucleated neutrophil, then there is a hyperlobated neutrophil, micromegakaryocyte, macromegakaryocyte, Pelger UAE anomalies, two-lobed neutrophil. These all are the various abnormalities you can see in myelodysplastic syndrome. And here there is a cytogenetic abnormalities present. And the hallmark of this, they are usually hypercellular marrow. And in our case, there is a hypocellular marrow. Our case is hypocellular marrow, not hypercellular. Let's go and check it. What is a bone marrow? So bone marrow is hypocellular. So acute myeloid, acute lymphoid, and myelodysplastic syndrome all have a hypercellular marrow. Any condition in bone marrow, number one is aplastic anemia or hypoplastic anemia. That is aplastic anemia. Hypocellular, hypo means less, and hyper means more. How do you know this is hypocellular or hypercellular? So say for example, these are the cells in the bone marrow, just for your knowledge. There are plenty full of cells, normal cells, right? And in hypoplastic bone marrow, it is less. In hypoplastic, it is less, right? So hypoplastic is less, very less number of cells in the cell, in the bone marrow. So it is hypoplasia. Cellularity is gone. Very scanty amount of the cells in the bone marrow. So it is hypocellular marrow. So concluding our talk, what could be the diagnosis? So diagnosis is none other than aplastic anemia. Let's dissect it. Clue here for the scenario. Clue. Fatigue and breathlessness our patient has, that is anemia, recurrent infections, leukopenia, bleeding gums and breast because of low platelets, so he has a pancytopenia. Anemia, leukopenia, thrombocytopenia, cumulative called as a pancytopenia. Number one, this is clinical cue, everything is there in our scenario. Low retic count, yes. Bone marrow, how is seen in aplastic, hypocellular and fatty infiltration, it is there. It is diagnostic. No bone marrow is hypocellular and fatty except aplastic. What is in AML, ALL and MDS? It is hypercellular and no fatty infiltration. No fatty infiltration. No fatty infiltration. Here fatty infiltration. No lymphadenopathy, no hepatomegaly. That also rule out the leukemia lymphomas, because in many leukemias lymphoma there is a hepatosplenomegaly, lymphadenopathy, bone pain, everything is there. And pesticide exposure is clue to aplastic anemia, chemical exposure, chloramphenicol, chemotherapeutic exposure can cause, which is the classical presentation. So if you go and read it, everything is matching. They are saying recent exposure to pesticide. So our case is fatigue because of low HB, breathlessness because of low HB, recurrent infection, low WBC count, bleeding, low platelets, so pancytopenia. This is clinical presentation, right? No, no, this is not which is commonly seen in leukemia lymphomas, which is not there, right? Recent pesticide can cause aplastic anemia, bone marrow suppression, right? So this is the classical things, classical presentation of aplastic anemia, right? So that's it. And this is the last take home message slide for you guys, right? This is right one line differentiating point. If it is AML, usually adult, you can see more than 20% blast and or rods. What do you mean by or rods? So this is a cell, this is a nucleus, and there is a rod-like structure in the cytoplasm. Rod-like structure or rod is equal to AML. I have mentioned many times in my hematology class, or rod is equal to AML. That's it. It is none other than AML. So if you see the or rods like this structure, rod-like structure in the cytoplasm, it is AML. Don't read the options. Tick AML. You are right. ALL, usually children, lymphoblast, lymphadenopathy. Nothing is there in our case. Multiple myeloma, usually 60 plus, bone pain, monoclonal protein, abnormal plasma cell, hypercellular or is hypocellular. Aplastic, pancytopenia, yes we have. Hypocellular marrow with fatty tissue, yes we have. No organomegaly, yes our patient does not have organomegaly. MDS, elderly patients, cytopenia, but hypercellular marrow. Our is a hypocellular marrow, which is not a dysplastic, normal looking. So here two things, hypercellular but plus dysplastic. Aplastic, hypocellular, no dysplastic marrow. That's it. So concluding our talk, hypocellular marrow, it is none other than aplastic anemia, hypercellular with cytopenia, either MDS or leukemia. How you differentiate between MDS? More than 20% of the blast in blood or bone marrow leukemia, less than 10% with dysplastic changes, with cytopenia, with cytogenetic abnormalities. It is a myelodysplastic syndrome. So that's all from my side for today. Thank you very much all for listening me coolly and calmly. You go and read the treatment part of aplastic anemia. Probably will
Sir,
cover
I
in
have a
the
question.
next
Sir, I
session.
have a
Thank you.
question.
Yes, please ask the question.
Sir, if there in a plastic anemia there is pancytopenia, then why not there is splenomegaly? Why we how
Because
what is
there is a
mechanism?
the mechanism is that aplastic anemia, there is a T lymphocyte which produces the abnormal antibody and attacks on the stem cell, right? So this is considered to be an autoimmune kind of things where the antibody kills the stem cell, and the treatment of choice is ATG, anti-thymocyte globulin. Leukemia, or I mean splenomegaly or hepatomegaly, usually develops when the excess of abnormal cell or blast cell, they infiltrate first in the blood, then bone marrow, then liver, then spleen, and then lymph node. So excess of the abnormal cells, like excess of glucose deposit in heart, ischemic heart disease,
Hmm.
excess of glucose
Hmm.
I mean deposited in eye, diabetic retinopathy, excess of sugar deposited in kidney, diabetic nephropathy, excess of sugar deposited in peripheral neuropathy. Are you getting me? Likewise, excess of the blast or abnormal
Yes, Minister.
clinical cells, they gets deposited in the liver, spleen, lymph node, and they present with the lymphadenopathy, hepatosplenomegaly. That is not the cause in aplastic, but yes, it is in acute leukemia. Yes, it is in the lymphoma. That is why they present with the hepatosplenomegaly, lymphadenopathy, blah blah blah. Is that clear?
Okay, because this is there is a phagocytosis by
Yes,
autoimmune procedure.
yes.
Okay, now today I understand. Thank you very much.
Wonderful. Any other question? Whew. Fine, that's all for from my side. A couple of more slides, but we are speaking for more, almost 1 three and a half, 3.5 hours from the exhaustive session, like one full whole movie sessions. We took it with full energy and excitement. So thank you very much once again all for joining me. Before I leave up my sessions, I would like to have very quick, genuine feedback. How did you enjoy the class? Please. Especially those who joining me the first time. Obviously, I mean, many people have heard me a lot of times probably, but
Speak
still,
if nobody minds. So I really like
doctor.
your session, doctor. It was very, can you hear me properly?
Yes, please. I can hear you, madam.
Yeah, so yeah, the class was awesome. It was really good, especially you were clearing the concept. I like that. But for me, the timings are not good. The class was very good, but the timings are not good. And rest is
Yeah,
all
so
fine. Yeah.
so we'll sometimes match with your US time. Sorry, but I must thankful to you
Yeah, the
from whole
class is
class.
very good and it's really very nice. I want to join it again, but the timings are not good. That's why.
Fair enough.
But everything is awesome. That's the way you explained everything. That's too good. Even I think so. If I just listen to these lectures, they're far enough to learn things.
Fair enough.
Yes.
Because this all take home message and we just do the crisp of the subject. No here and there talk. What important for the exam, we'll just target that. That's it. Yes. Anyone else? Thank you very much, doctor, for your kind feedback. Serena. Yes, anyone? Dale? I think you joined first time. Dr. Safni, I think I can see you first time. Ranmini, Nafla, rest of the people I know because they are many a times in the class. Nahid, Akbar Arun. Yes, anyone, please? You can tell if you don't like, no? Don't worry, we'll improve it. So it's not always you have to tell good things. Yes, anyone? Anisha, how did you enjoy today? Anything new learning?
Uh, yes, sir. As usual, it is excellent. Lecture was excellent and wonderful, and we learned many new things today, especially these Hodgkin's lymphoma and non-Hodgkin's lymphoma that I have confusion since long time, but I cleared my doubts, clear my this, and it was a concept clearance lecture. It was wonderful.
Wonderful,
Thank you.
wonderful, wonderful. You are a great doctor. Wonderful. Yes, anyone? Last but not the least, any comment? I would be happy if
Dr.
what
Manju,
did you learn?
I'm so
Yes,
thankful. Yes, I'm so thankful. It is so amazing as you used to be, and I'm following your classes again. So happy to catch many important points that I have already missed in my own study.
wonderful. Wonderful. So we have many hundreds of videos on our YouTube channel. So as I told you before my class that you see at least one video a day, lots of concept clarity. And let me tell you one more thing. Every video is different. So extremely less chance that you have repeated question in each mock test because we are designed in such a way that we every time add the new pool in our mock test on every Sunday. Thank you very much. Anyone last opportunity of one? Anyone? Dr. Ramya, how did you enjoy it if you are in the class?
Sir, I always enjoyed your classes. I always enjoy and learn a lot of new things. Well done, I
Wonderful.
must
Thank
say.
you very much. Thank you.
Dr. Manjul, sorry, one question because
Yes, please.
unfortunately I was able to attend in the last hours and I was not in your introduction again. Just it would be I would be so thankful for all over if you summarize your plan for 2026 who are for DHA or for all GCC countries. Is any pattern has
Yeah.
the same things is going on? If you are able to summarize in few seconds.
So, means what your question is about DHA?
Yes, DHA, yes.
So basically that everything is same, doctor. Nothing changed for last many years. I'm coming, going. As I told you, I'm again coming on 7th of the February after a couple of weeks. So we would love and meet you as well. Those who are in UAE, Sharjah, Abu Dhabi, or Al part of UAE. So it is same, doctor. 3.5 hour of exam, 65% is passing score. Three attempts in a calendar year. So I don't think, anybody needs a three attempt to pass the exam. You probably have no trust in yourself, but I have trust in yourself. If you go through the system the way we are doing it properly, just matter of 2 months. Anybody can crack the exam in 2 months. Maximum, max to max is 3 months. Believe me, max to max is 3 months. So just stay tuned with us. Do let us know if you need any help, any subject you are weak into it. Will That is why we are now recently creating Dr. Akanksha for last 2-3 times the pool, right? So you just need to spare 5 seconds and give the answer in the pool that what exactly the subject you want to learn or understand, so we can design the MCQs accordingly and will present in front of you to strengthen your weaker subject. So everything is same, don't worry, stay tuned with us. Do let me know if you need any help. So that's all. Thank you very much all for joining, listening me coolly, calmly. Thank you. Stay tuned. Enjoy your Sunday. Thank you very much.
Yeah. Thank you so much. Thank you so much, Doctor.
Yeah, bye bye.